And we should be. We are on Facebook and we are live and we are open for attendees. It is 6:01 p.m. on June 9th, 2022. If you're watching on Facebook, you cannot ask questions during this presentation through the Facebook profile platform. You will need to log into the webinar. The link for the webinar is located in the information on Facebook. This session will be also available after today on our YouTube channel and also probably on our website in pieces. Good evening, everybody. My name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association. And for purposes of tonight's meeting, we're going to do things a little bit different because our Big Hearted Warrior Tour typically has a featured center. And this is a slightly different objective. This is a special presentation for pediatric and adolescent HCM. Tonight, we have some pre-recorded segments that we will be playing from a couple of individuals who were unable to be here with us this evening. And then we have some live presentations and we'll have live Q&A at the end of the evening. If you are watching on Facebook, we will again not take questions directly from Facebook. You will have to join the webinar. At the conclusion of our streaming on Facebook, we will take a couple additional questions from the webinar, and then we will stop recording of the webinar. So if anybody wants to ask a private question, private to those who are in the webinar, but not held in posterity on the internet forever and ever, amen, you will be able to do so at the very, very end of this session. So that being said, I want to introduce two members of my team, Amy Mann, my meeting coordinator, and Julie Russo, our volunteer coordinator, who are here today to assist us. And if you have any questions, you can go into the chat and Julie and or Amy will assist you. If our faculty has any issues, they can message Amy or Julie and they will help you too. So I am going to now go around those who are here with us in person, and then I'll introduce those who could not be here in person at this point. We're supposed to be joined by one other faculty member at the end of the night for questions. Christa, and now I'm going to try to Miliaresis. I can't. It's Greek, and I'd say it when you say it to me, and then I get it wrong because you have a married name and a professional name. So, Christa, would you introduce yourself to our audience?
Hi, I'm Christa Miliaresis. I'm one of the pediatric cardiologists with Boston Children's Health Physicians in New York. I am the director of the pediatric HCM program at Westchester Medical Center, and I am thrilled to be here.
And we are thrilled to have you. Balaji from the West Coast. So you want to introduce yourself, unmute.
Yeah, thank you for reminding me to unmute. My name is Balaji. I'm a pediatric cardiologist and electrophysiologist. I work at Oregon Health and Science University in Portland, Oregon. I have had a long-standing interest in hypertrophic cardiomyopathy in children. And again, I'm really delighted to be invited to this meeting. Thank you.
Thank you for being here. And next up, we have a really big diehard fan of, I believe, the New York Yankees. Is it, Peter?
What's that?
I thought you were a Yankees fan. Oh, wait, is that the Red Sox?
I gotta go. Gotta go.
Peter Fischbach from Atlanta. Peter, say hi and tell everybody where you're from.
I'm from Atlanta, but a diehard Red Sox fan. And I am at Emory University in Children's Healthcare of Atlanta. And we have a big hypertrophic cardiomyopathy program focusing on pediatric patients. And I have a long-standing interest in the care, multidisciplinary care of these fascinating and courageous young people.
Fantastic. We have sessions coming up to you tonight from John Jefferies and Shari Jefferies. They'll be at the end of the night. And our keynote speaker unfortunately got ill this morning. So Jeff Towbin was kind enough to record his presentation, which will be presented immediately after I give a couple of points from the HCMA's point of view. I did also want to thank our sponsors, and we'll get to that in just a moment. And to remind you that there's a poll. If you're logging into the Zoom room, you can take the poll. Slow attendance. It's early on the East Coast here, so we have some people joining us a little bit later, I suspect. And we're going to try to keep a good cadence tonight. So if there might be something else going on TV that some people might want to watch tonight. I don't know, it might be a thing. So we'll hopefully get you off to that pretty quickly. I am going to share my screen and get my slides up. Hold on, multi-windows. Oh no, I'm going to do that. Share the screen, and then we're going to go to here. Okay. So, oops, sorry. We have a special announcement tonight, and unfortunately, it's a sad one. I found out earlier today that one of our pediatric HCM transplant warriors, Jaden, passed away yesterday from complications of her transplant. These pictures were taken in April of 2019 when Jaden and her family made their way to New Jersey, and we were able to go to the pasta shop together and have some fun, and I got a couple hugs, and we were able to meet each other. Jaden's brother, Deshaun, passed away in 2014 from mismanaged HCM and didn't get to transplant in time, and unfortunately, Jaden didn't, she's no longer with us. She was a very sweet girl, and our condolences to her family and all those who are grieving her loss. It was quite shocking to get that news today. So what do I do when something not good happens? I try to spin it into something positive. So my hope is that tonight we will spread some awareness about pediatric and adolescent HCM, from the clinical to the psychological and everything in between, in hopes that we can make some positive differences for other young people coming behind her. She was 12 years old, and I was 12 years old when I was diagnosed with HCM. So I remember being 12. Being 12 is hard, and being 12 with HCM is hard, and being 12 with HCM transplant is hard. And it was a challenge. So God bless you, Jaden. We will miss you. Tonight's special edition is brought to you through our event sponsors, Boston Scientific, Invitae, Bristol Myers Squibb, and Cytokinetics. And we thank them for their financial support so we can continue to make programs like this available for you all. I do want to make a programming note. The information that you're about to hear tonight is educational. We cannot do consult by webinars. So if you want to ask questions through the evening, there will be a question and answer area that you can populate. However, we cannot address very specific consult by webinar kind of questions. So if you ask a question, I may moderate it to generalize it for the audience, and we're happy to address it that way. You should not take this as medical advice. You should take this as medical education and have an educated conversation with your chosen healthcare provider about the topics that we're going to be discussing this evening. We are going to get into some deep topics today. Jeff Towbin has a wonderful talk that we'll be playing in just a few minutes, and he's going to be talking about from babies to young children and the HCM spectrum disorders. So we're going to kind of go into the syndromes, and we're going to talk widely about how HCM is really defined in the pediatric age group, which is a little bit different than the adult age group. We're going to then jump into disease management and forward thinking, clinical trials, maybe coming, hopefully. We're going to talk about sudden cardiac arrest, prevention, and arrhythmia management. And then the big topic that everybody always wants to know about, athletics and children with HCM. So Christa, good luck on that one. That's always a tricky topic. We're then going to take a jump into psychological well-being, and we have a really interesting presentation from Shari Jefferies, who is a psychiatrist. I always get that one wrong. I'll get that right in a minute because my screen is being blocked. And then we're going to hear from John Lynn Jefferies, who's going to talk about transitioning from pediatric care to adult care. And then we'll do your Q&As. Okay, so oops, this is a little out of whack. Uh-oh. This is what happens when I try to do things quickly. So I have to tell you that I'm in Washington, D.C. I'm in a hotel room, if you can tell that it's not your typical HCMA backdrop. And I was at a policy conference earlier today where we were discussing pressing issues of the regulatory and access issues related to HCM. So one of the things that we were talking about here is something called the Healthy Cardiac Monitoring Act, which is a piece of legislation that the HCMA is trying to plant in basically every state. We have it in New Jersey. You can learn more about it on the website. You'll see this image, so you can just kind of go on there and learn more about the Healthy Cardiac Monitoring Act. The basics are this. We know sports physicals include 14 cardiac points, but recommended by the American Heart Association. We also know that when you look at the sudden death in athletes registry, about 35 children, young adults, die every year from cardiac related issues, the majority of which being hypertrophic cardiomyopathy. But what else do we know? From the Wonder database, which is kept by the CDC, we know that about 150 young people every year die from hypertrophic cardiomyopathy, which would mean only 20% of them are athletes. So we want to look at all children's hearts equally and give physicians the education that they need to understand what it is that they're looking for, so they have an opportunity to identify the child and the family who might be at risk of HCM or other disorders. This isn't everybody on the deck here, people. Dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, channelopathies, congenital defects. We want to find it all through the Healthy Cardiac Monitoring Act, and we need everybody to jump on board and help us get this passed. We're winding things up. We have different calendars for different states and when their legislative bodies come into session. So stick with us, sign up to be a volunteer. Julie will communicate with you when we're going to be working in a particular state. You don't have to wait for your state. You can help us get other states passed, and then other people will come in and help your state get passed. So come on board, people. We want to get that going. If you are out and about in the community and you have a community cardiologist, we would like to help that community cardiologist understand HCM a little bit better. So we have created something called HCM Academy. It is in partnership with PCM Scientific, a medical education company, and the CME credits, which are free for your doctors, are managed by Scientifica CME. This program is a multi-pathway, 6 online CME modules, 5 online case studies with the amazing patients of the HCMA featured. There's some amazing stories. You want to go watch those. And then there's 5 online non-CME patient perspective videos. Again, the same 5 people. They're awesome. And then once your physicians have taken the online courses, they can join an online educator to go over points that maybe weren't clear enough in the online, or ask questions, clarification, and take a deeper dive into HCM. It's an amazing project. We're really happy and proud to be part of it, but we need people to start taking the courses. We had 11 new physicians educated, I believe, yesterday in a session run by Eugene DePasquale in LA. And we have more programs coming up for your physicians to take and learn about HCM. The financial support for that program came from Bristol Myers Squibb, Sanofi, and Cytokinetics. They gave the funding. The faculty, which was up here, myself, Marty Marin, Anjali Owens, and John Lynn Jefferies, who you'll be hearing from later, created the curriculum. And it is a phenomenal program, if I do say so myself. You can go right onto the HCMA website and go under programs, and you will see the HCM Academy information right there. And you can refer your own provider. If you have an email on your doctor's office, you can put your information right in there, and we will communicate with them and offer them a class. If you are a provider, you can click right on the provider link and you can get communicated with that way. So I want to take a moment. I can't announce something tonight because I didn't tell the director of the program yet because it got approved in last night's board meeting. So stick with me. There's another program coming. But the HCMA Center of Excellence program is growing. As of right now, this is a little bit older. We have 45 programs. I have a typo on this one. This is what happens when I'm in a hurry and on my laptop. But as of tomorrow, there'll be 46. I don't know if we're going to formally announce it tomorrow or not, but when I get done here tonight, I'm going to call the director and let him know the good news. The concept of a center of excellence is simple. We want to ensure that all patients have a multidisciplinary approach to care. The physicians who you're hearing from tonight, all of them are either longtime HCMA recognized center of excellence physicians, or 1 or 2 of them may have moved to a new center, and I'm working on getting them onboarded again. So what do we know about HCM Center of Excellence care? It's so good that in the most recent guidelines issued by the American Heart Association and the American College of Cardiology, that they recommended our model of care for all patients with HCM. Of course, they did not refer to it as being an HCMA model, but that's okay. As long as everybody's getting competent quality care, that's what matters. If you are joining us on Facebook, you know about our Facebook page. If you're joining us in webinar, you may not know about it yet. So here's where you can find support. We have our forward-facing page is where you can find programs and information that we're pushing out. We have 2 private groups that are directly tied and managed by HCMA staff. The private group is almost 9,000 people now, so it's not really private, but it's not public on your feed, so people can't see what you post there. So if you want to talk to your fellow big-hearted folks, this is a safe place to do so among 9,000 of your formal diagnosed brethren. We are also working on a program called HCMA International. We have programs and relationships that we are building out with different countries. And each one of those countries will be getting their own Facebook presence where they can discuss HCM in their own language with trained moderators from that country. There's more going on in HCM International, but we are not going to spend a lot of time talking about that tonight. If you haven't joined a discussion group yet, we encourage you to learn more about them. We have phenomenal peer-to-peer support through our online discussion groups. Every day, almost every day of the week, there's a discussion group. We have probably about 100 and some odd opportunities per month to join a discussion group. And you can talk about emotional wellness, devices, surgery, coping with HCM, newly diagnosed, planning a myectomy. We're probably going to be adding a couple of other groups. One might be the Medicare population discussing strategies to make the most of your Medicare, not exactly for this group. And then another one that's been requested is family support for not the diagnosed person, but the family members. So we are working on building that out, but slowly and steadily so that we can do it in a sustainable manner. If you have followed any podcasts, I podcast hopefully every Friday, unless I have COVID like May killed me. Don't get COVID, get your vaccinations. Bad to get COVID. Tomorrow I will be meeting with Colleen Kalishu, who is a genetic counselor who I've been working with for over 15 years. And we're going to start a 2-year project where we're taking a deep dive into genetics. Tomorrow is kind of the kickoff. So if you want some foundational information about where did genetic testing come from? How does it work? What is next-gen sequencing? What is GINA and who can get access to my genetic testing and et cetera? We're going to be starting from there and we're going to build out our knowledge over about a 2-year period through webinars and podcasts. Why is that important? Genetic testing is easy. You put a swab in, you send it off to a lab, they give you a report. It's way more complicated, people. And we have several companies right now starting to investigate genetic therapies for HCM. And if those trials start to come around, we want the HCM community to be ready to have an engaged conversation with a clinical trial coordinator and understand genetic therapies. But that doesn't happen overnight. It's going to take time to build up everybody's knowledge. So tomorrow we start and we build up everybody's knowledge and we bring thought leaders to the table so we can have robust discussions about where we're going in medicine. And genetic therapies are already here. Danon's disease has a therapy that they're trialing right now. If the concepts work, there could be something curative for some people with hypertrophic cardiomyopathy. So starting tomorrow, we take a dive. Speaking of genetic testing, the HCMA is happy to tell you that Invitae does provide free genetic testing. Now, I like to take a moment here to explain free because most adults will say there's no such thing as a free lunch. So let me explain how you actually can get a free lunch and who's paying the price. When the physician orders your genetic testing, there's a form the physician signs. You also consent. Your information is private. Nobody can get your information other than the physician who ordered it. However, if a genetic marker comes up for one of the HCM phenocopies, let's just say Fabry's disease, a representative from that company can contact your physician and say, we understand somebody just tested positive for Fabry's disease. Are you aware of our therapy? That's the price. So the patient gets the information on the latest and greatest treatment for whatever their genetic disease is, if it's not truly like sarcomeric HCM, if it's one of our phenocopies. So that's who's paying for it. The pharma companies who provide those therapies. And that's how. Any other questions? I'll be more than happy to answer them for you. I'm going to just thank our partners here, our Recognized Center of Excellence partners, our partners on the faculty tonight, the staff of the HCMA, our board, our volunteers, and of course, Brandy, my donor, because without her, I wouldn't be here today. So I'm going to end my presentation. I'm going to stop my screen share. And I am going to ask Julie to screen share. And she has Dr. Jeff Towbin's, don't start it yet, Jewel. Give me a second. Jeff Towbin is probably one of the smartest, most intelligent people that I've had the opportunity to work with over the past 25 plus years. Jeff is currently the executive co-director of the Heart Institute and Professional Cardiology Program and the chief of pediatric cardiology at Bonheur Children's Hospital and St. Jude's Research Hospital, as well as being the vice chair for pediatrics and strategic advancement for the University of Tennessee Health Science Center in Memphis. He is one of the most learned individuals in pediatric cardiomyopathy. And those who are on the call who are pediatric cardiologists or electrophysiologists will shake their head and go, yep, Jeff kind of knows it all. We are going to take a few minutes. He's going to have a little bit longer talk than our average talks here at HCM Bighearted Warrior Tours. But he's going to talk about babies and young children diagnosed with spectrum disorders and the genetics of HCM. This is going to be a fascinating talk. I've had a sneak peek at parts of it already. So Julie, why don't you hit play and our faculty can turn off their cameras and mute themselves as we listen to Jeff
Thanks for the
Towbin.
introduction, and thank you for allowing me to give this talk tonight. Thanks specifically to HCMA. And let's get started. My talk tonight is going to be babies and young children, diagnosis, HCM, and HCM spectrum disorders and genetics, no disclosures. So the classical diagnosis of HCM and its pathophysiologic features include LV hypertrophy with asymmetric septal hypertrophy, most typical, small LV chamber, hyperdynamic systolic function with poor relaxation or diastolic dysfunction, with or without LV outflow tract obstruction. The difference between HCM and HOCM, the obstructive form. Myocyte disarray, fibrosis, diastolic heart failure, all occur in this disorder that is also known as HFpEF, and certainly arrhythmias can also be seen. Burnt out form of hypertrophic cardiomyopathy can also be seen, which means that the LV dilates and develops systolic dysfunction associated with the hypertrophy and the diastolic dysfunction that had occurred previously. There's a high risk of poor outcome in young children, particularly neonates and infants, who commonly have a different underlying etiology of disease than the older children and adults who most typically have sarcomeric gene defects. These patients tend to have more metabolic-based disease or syndromes. And there's a high sudden death risk at any age, but in the infants and young children, there's a significant risk at that point. This just demonstrates classic features of HCM with the thick interventricular septum encroaching on the LV, so you have a small LV chamber. In real time, you'd have systolic function being better than normal with a relaxation problem. Here are some pathologic specimens, normal versus hypertrophic cardiomyopathy with asymmetric septal hypertrophy versus those with concentric hypertrophy. The classic form of disease is the asymmetric form of disease, particularly seen with the sarcomeric-based disease. Fibrosis and myocyte disarray are commonly seen on histopathologic examination. Here are some imaging features, echoes, and cardiac MR of the thick LV on this parasternal long axis view, and on short axis view, you can see the septum being quite thick, the LV dimension being small. Here's a 4-chamber view where again you see the very thickened LV with a very thick interventricular septum encroaching not only on the LV chamber but on the RV chamber and normal atria up top. Here is where the left atrium is dilated. So this is a restrictive cardiomyopathy form of hypertrophic cardiomyopathy. There's no mitral regurgitation in this particular patient population typically. And so it's a diastolic dysfunction problem that occurs in these patients. And they have a higher risk of bad outcome than straightforward hypertrophic cardiomyopathy, which already is an at-risk problem. Here is hypertrophic cardiomyopathy with obstruction to LV outflow tract, and also MR seen on this evaluation. This demonstrates the burned out form of disease. You can see that the LV that was thick and hypercontractile is now dilated, thinner walled, and in real time poor systolic function. So in the pediatric population, prenatal and family history is critical to get. Were there family members with hypertrophic cardiomyopathy, particularly if they were genetically diagnosed? Are there other members of the family with syndromes or metabolic disease? To work the patient up that comes in with hypertrophic cardiomyopathy type of imaging, urine analysis, urine organic acids, urine amino acids, acylcarnitine profile, all need to be done to rule out metabolic disorders, liver function studies, as well as considering lactic acid, pyruvate, liver function tests, serum amino acids, creatine kinase to see if there's a muscle relationship, CK-MM abnormality, troponins, BNPs, acid maltase deficiency being looked for the rare case of Pompe disease, which we see in our neonates and infants. Consider a skeletal muscle biopsy, looking for histopathologic and electron microscopy features of metabolic-based disease, and then genetic testing for both autosomal dominant, recessive, or mitochondrial-based genetic disease. These are the initial genes that were identified in HCM. They're all encode for proteins of the sarcomere, so this has been called a disease of the sarcomere. However, in young children, non-sarcomeric gene disease, it's also not that uncommon. While it's uncommon in the older patients and adult patients, in the babies, we see a slightly different form of disease that is not specifically a disease of the sarcomere as a primary problem, but a disease of the sarcomere secondarily due to abnormal functioning of metabolic pathways or syndromes. These are commonly called phenocopies of HCM or phenocopy HCM. And these would be most common in infants and young children. And as I said, multi-organ disease is most common in this patient population. And neuromuscular signs and symptoms are commonly associated with the heart muscle disease in these individuals. Also, on testing metabolic abnormalities and on physical features, syndrome features may also be seen. Infiltrative and storage diseases would make up some of these infantile forms, which would be the Pompe disease, Danon syndrome, later Fabry and mucosal polysaccharidoses can be seen along with MK deficiency. Mitochondrial-based disease like MELAS and MERF, Sanger syndrome, Friedrich's, and Barth syndromes can also be seen along with metabolic disorders, VLCAD and MCAD, most typical. We can see carnitine deficiency, and in those burnt out forms of disease would be more commonly seen than with other forms of hypertrophic cardiomyopathy. So with phenocopies, the sarcomere is secondarily affected due to problems with energy depletion or misuse. The other phenocopy that is sometimes missed would be the left ventricular non-compaction hypertrophic cardiomyopathy form of disease, and I'll show you an image of that a little later. So as I said, the original forms were sarcomeric based. The first metabolic based form of genetic form of hypertrophic cardiomyopathy, autosomal dominant, was AMK deficiency, as demonstrated by the chromosome picture here and the position of the AMP kinase gene. And you can see where the metabolic system that AMK is a key member of, and like mitochondria itself, the development of ATP energy to feed the sarcomere for its function is key. And if you disrupt this, you end up with a problem with providing energy to the sarcomere for its normal systolic and diastolic function, and you end up with a clinical phenotype, most typically hypertrophic cardiomyopathy. And there's some infiltration of material into the myocardium in addition to its energy depletion. The other classical infantile and baby form of hypertrophic cardiomyopathy is mitochondrial disease, either through mitochondrial DNA abnormalities or non-mitochondrial DNA abnormalities. But mitochondrial function, this is the power pack of the cell. It's the energy producing part of the body. And as mentioned with the AMK deficiency, ATP generation is critical for the functioning of the sarcomere, as demonstrated here in this Netter figure. You can see the sarcomere here. You can see the positioning of mitochondria all around the sarcomere, being close by to provide the energy necessary for the function of the sarcomere. So it's energy requiring to go, and the mitochondria would be the basis of that. And in the sarcomere, the ATP requiring ATPase of the sarcomere is the myosin heavy chain, as demonstrated here. This is the heavy chain that requires the energy directly supported. So mitochondrial-based disease, I should mention, tend to be systemic, not just a cardiomyopathy, but associated neuromuscular disease, abnormal brain function, liver function disorders, and others would be typical. So this is a multi-center, multi-system disease that you have to pay attention to. Again, most typical in babies, but these children are living longer these days. So the other cardiologists and adult cardiologists might see these patients as time goes on. Same thing is true with fatty acid oxidation defects. Hypertrophic cardiomyopathy is common associated with them. So would be overlap cardiomyopathies of the dilated or hypertrophic form of disease. Fatty acids account for 70% of the heart's energy needs. So if these aren't working properly, you're going to end up with a mitochondrial type of disease with an energy mismatch. These patients tend in the infantile stage to be noticed to be floppy babies because of their muscle-related disease. This demonstrates some of the systems, metabolic systems in mitochondria demonstrated here, and the structure of the mitochondria and how it develops ATP energy. But some of the other key metabolic based disorders also identified there, and with fatty oxidation defects demonstrated in the panel below. Other HCM phenocopies, this would be left ventricular non-compaction of the hypertrophic cardiomyopathy form. You can see the asymmetric septal hypertrophy and the apical hypertrophy, which really are individual fingers of heart muscle. This is LV non-compaction at the apex and of the LV free wall. You don't see it in the septum, except for the apical portion of the septum occasionally. But this would not be a straightforward HCM. This would be the hypertrophic cardiomyopathy form of non-compaction. On this side is a child with Noonan syndrome, the classic features of broad forehead, ptosis of the eyelids, hypertelorism, and some of the other features as outlined here. Low set ears also prominent in this patient population. Hypertrophic cardiomyopathy, commonly associated, ASD and PS can also be seen in this patient population. In other childhood and adolescent forms of disease, you can see when we compare it to babies and older kids, the percentage of deaths in all of the kids, very high percentage of deaths in the babies, infants, in all comers. And you can see here the patients presenting in less than 12-year-old experience death or transplantation, typically, most commonly in the middle of childhood. This from the Pediatric Cardiomyopathy Registry. You can see again the bad actors or the bad players, death from of diagnosis on. You can see that the mixed HCM, DCM type of disease has early drop off, as do those with malformation syndromes. And down here, you can see those with the mixed type, but worse in the inborn error of metabolism. So not only early on loss of patients, but continued loss over time. These are, from the pediatric perspective, the worst outcome cardiomyopathy patients. So to summarize, hypertrophic cardiomyopathy differs in children compared to adults. The age of onset in childhood influences the diagnosis of underlying etiology as well as the outcomes. In younger children, inborn errors of metabolism are high risk. Patients that have bad outcomes, typically secondary sarcomeric function abnormalities are seen in these metabolic forms. Primary sarcomeric gene defects are most common in the older patients outside the neonatal timeframe. Therapies may differ in children with HCM versus the adults due to the differences in etiology, particularly in the neonates and young children. And so understanding the genetic and metabolic causes of disease of childhood is important, and targeted therapies could be developed and improve the ultimate outcomes. Thank you. Happy to answer questions.
Thank you very much to Dr. Towbin, who sent in that video earlier today and is not able to answer any questions at this time because he's not here right now. However, we have some other expert pediatric cardiologists and electrophysiologists who could field a couple of questions. If you have anything to post right now, or if you'd like to hold questions till the end, we can do that as well. You can use the Q&A feature at the bottom of your Zoom browser, and you can post your questions there. Being that he is not here to take any questions, or I can't ask him my typical Oprah style clarification questions, I'm just going to move on to the next speaker. You can put your questions in at any time, and any of our faculty can address them in writing, or they can be held for verbal review at the appropriate times. So we are going to move to Dr. Peter Fischbach now, who I was teasing him. In his bio, he said, I'm a Red Sox fan. I'm like, I'm a Jersey girl. I got to bust you about the Yankees. So he is not a Yankees fan. Peter, I hand it off to you to give us your excellent speech.
All right, let's see if we can set this up.
There you go.
And hopefully everybody can see this.
That we can.
All right, so I've been charged with talking a little bit about the medical management of hypertrophic cardiomyopathy.
You may want to put that in present mode.
All right, let's see how we can do that.
That little picture on the bottom or that little picture on the top.
Let me see if that helps. Nope. Let's see if that helps. Nope. You know what? Well,
At the bottom of the screen by the sizing, and then you want to swap screens because you're in the wrong view. So
yeah,
if you go up to
apparently never
display
had-
settings, if
Let's
you go to the top of the browser by display settings and do swap, you'll have it right. Oh, no.
Okay, so if I
not
go
that one.
back to this, you say, and then go wait for it to click in. And you say display settings.
You can get there yet.
How's that?
Nope, still the same. There it is. That looks perfect.
Now it's perfect.
Now it's
Alright, well-
perfect. I'll go away now.
I'm still going to talk about medical management of hypertrophic cardiomyopathy no matter what. And I may spend some time talking about the many reasons why hating the New York Yankees is actually good for your soul. But like everything, we should probably think about where we're going with this whole thing so we don't get lost along the way. So give a brief little overview, 35,000 foot view of kind of where we are with medical therapy for hypertrophic cardiomyopathy and kind of what's coming down the pike. So about 65 years ago, Dr. Kerr really described hypertrophic cardiomyopathy. And before it had always been known as a kind of tumor of the heart. So certainly pathologists had been describing this condition for millennia, but really not until this seminal work was it understood that this was a disease of the heart muscle rather than just a tumor. And these were 8 patients who had asymmetrical hypertrophy, and as he described it, a muscular hematoma of the heart. And he kind of went on to talk about the bizarre pathology that they found on microscopic examination of these hearts as well. So I just thought we'd talk about kind of the history of treatment for hypertrophic cardiomyopathy, and just I needed to pick a starting point. So I took 1999, because that's the year I finished my clinical training. And at that point, first line therapy was beta blockers. Second line, for those who didn't tolerate beta blockers, were calcium channel blockers. And then if you didn't tolerate either of those, you got disopyramide, and people would get diuretics or amiodarone to treat heart failure and arrhythmias. So this was essentially like going to your doctor with strep throat and walking away with throat lozenges, because they were really addressing symptoms and not necessarily underlying pathology. So fast forward to 2020, and 2020 is because the American Heart Association and American College of Cardiology had their latest guidelines for the diagnosis and treatment of hypertrophic cardiomyopathy. And you can see the great strides we have made in terms of medical therapy. It's still beta blockers, calcium channels, disopyramide, and diuretics and amiodarone. And this is really, again, directed at treating symptoms, but we really have not addressed the underlying pathophysiology of hypertrophic cardiomyopathy. So again, we're getting throat lozenges. This is the unfortunate consequence that I think a lot of people are aware of. On the left is Journey Brown. He was a phenomenal starting running back for Penn State University. And in 2019, he was disqualified from participation because of hypertrophic cardiomyopathy. So the progression of his disease could not be stopped, and obviously had a major impact on his lifestyle and the things that he found important and wanted to keep doing. So now we're in a new era, and really starting last year and probably 2019, there have been several new therapies that have gotten everybody's attention and are now in clinical trials. Probably the most sexy of them all is mavacamten, which many of you have probably heard of or heard rumor of. And it really is a novel therapy. And it's one of the first medications that truly was developed for the treatment of hypertrophic cardiomyopathy. All the other treatments we've used have been drugs that have been used to treat other problems. And people said, hey, why don't we try this with hypertrophic cardiomyopathy? So these really are quite novel. There was a nice paper that recently came out with valsartan, which is an angiotensin receptor blocker, and that originally was used for hypertension, but has found several other uses in medicine. And then there's several other investigational drugs that are out there. So what about mavacamten? How does that work? Well, mavacamten is, and Dr. Towbin had kind of gone into the sarcomere and how the muscle contracts, but on a very basic form, the way that the muscle contracts is that the myosin thick filament reaches up and grabs onto the actin thin filament, and they pull each other in opposite directions, and that causes cardiac contraction, and that's an ATP dependent process. And what mavacamten does is it very specifically comes in and blocks that interaction between the thick filament and thin filament. And so it allows the muscle to relax a little bit more. So what that does is it ends up with more relaxed myocardium. So the diastolic function of the heart actually improves quite a bit. The volume of the left ventricle increases, and the contractile force of the ventricle decreases. So that decreases some of the outflow tract obstruction that can be generated with a very hypercontractile ventricle. There also is now some emerging data that this probably will help interrupt some of the downstream problems of hypertrophic cardiomyopathy, such as the fibrosis and further hypertrophy of the muscle. So this may, in fact, be a way to interrupt the progression of the disease and not only improve symptoms, but actually stall how fast the disease is progressing. My mentor once told me, and he had a great sign in his office, and it said, for every complex problem, there's a simple solution, ... and it's wrong. And I think many of the interventions for hypertrophic cardiomyopathy have found this. There have been several studies trying to interrupt the energy utilization within each of the cells, and they've had very mixed results in terms of being able to help out with hypertrophic cardiomyopathy. And the results from the early trials of mavacamten are actually very, very positive. I'm actually very excited about them. But we need to take a little bit of a step back because one, certainly for this crowd, these medications have really been tested in adults, and not only adults, but older adults, primarily in their 50s, 60s, and 70s, haven't been tried with kids. And there's also emerging knowledge that all of these medications seem to be a little bit specific to specific genotypes, so that one drug that may help one person with a specific mutation may not be quite as effective for someone else. So word of caution, but I think it's good news kind of coming at this point. And so really there have been three major trials that have come out in the last couple of years. The first was the Pioneer trial, which came out in 2019. And what you first notice is that it's actually quite few patients, only 21, and the average age was 57 years old, although they did have one 22-year-old patient in it. And that showed some good progress. Then came the Maverick HCM. The Pioneer HCM was for patients with obstructive cardiomyopathy. Maverick was non-obstructive. And then the most recent trial that I think has gotten the most press has been the Explorer HCM trial, which has really been a fascinating trial, again, with hypertrophic obstructive cardiomyopathy and symptomatic patients demonstrating marked improvement in the patients. And then most recently, the Valor HCM trial. So the first trial, the Pioneer trial, they just wanted to evaluate the effects of 12 weeks of mavacamten. So again, these are short trials. They're not 10, 20, 30 years, which is, if you're a 12-year-old diagnosed with hypertrophic cardiomyopathy, it's nice to know what's going to happen in 12 years, but really the interest in what's going to happen in 50 years. And the goal was to basically see, is it well tolerated and is it safe to use? And their primary endpoint was looking at post-exercise peak left ventricular outflow tract gradients. And again, these are symptomatic adults with hypertrophic cardiomyopathy. And there were two cohorts. Cohort A had a higher dose and cohort B had a lower dose. You can see the graphs on the top and the bottom there. The open boxes in the graphs here represent resting left ventricular outflow tract gradients. The one that are filled in blue represent exercise-related left ventricular outflow tract gradients. And again, what you see is this downward shift with a marked improvement in the resting LVOT gradient and the provoked LVOT gradient. And you can also, on the top, this line moving across is the left ventricular ejection fraction. And note that it falls from kind of this hyperdynamic state with an ejection fraction of about 70% down to kind of a low normal ejection fraction of about 55%. So on average, the ventricular function decreased, but still stayed within the normal range. And interestingly, also, these patients reported improved symptoms. And then one of the interesting parts of this is the same data, when they graphed the peak outflow tract gradient, how much obstruction there was to blood coming out of the heart, and graphed it against what the blood concentration in the patient was. Certainly once you got over a certain threshold blood concentration, there seemed to be a very consistent improvement in the response of the patients to mavacamten. Then in 2020, the Maverick trial was published, and this was mainly to assess the safety and tolerability of mavacamten in symptomatic patients with non-obstructive hypertrophic cardiomyopathy. So they went from the obstructive to the non-obstructive. And they were mainly looking at some of the biomarkers of cardiac function and showed that there was a marked improvement in the NT-proBNP and the cardiac troponin I, and both of those are markers of how well the ventricle is working. So it seems like they also reported a very positive outcome. Finally, the Explored HCM trial, which was a bit of a bigger trial, they again were looking at the safety and efficacy of mavacamten. The primary endpoints were exercise capacity and the symptoms that the patients had, with secondary endpoints of exercise-related ventricular outflow tract gradients. And then they started using a Kansas City symptom questionnaire, which gives a big composite view of how patients feel that they are doing. And certainly on all measures, the patients treated with mavacamten improved quite a bit, with marked decreases in the ventricular outflow tract gradients and preserved ventricular ejection fractions. I think in the total of 100 plus patients, there were 5 patients who had a fairly significant fall in their left ventricular ejection fraction, although this was reversible upon terminating the medication, and it wasn't clear what would have happened if they had continued with therapy. So again, very promising data out of all of these trials. Finally, the Valor HCM trial, and this abstract was just presented 2 months ago at the American College of Cardiology meetings, and this was looking at mavacamten in symptomatic patients with obstructive cardiomyopathy, and their primary goal was to see if they could prevent patients moving on to septal reduction therapy, so either myectomies or catheter-based alcohol septal ablation. And again, they showed a very significant improvement with fewer patients going on to septal reduction therapy, and some of their secondary endpoints reinforced this decreased ventricular outflow tract gradients, as well as improvements in patient well-being. So those are the kind of trials, but again, I call your attention to one, they're reasonably short trials. There are reasonably few patients who are enrolled, and this is primarily in older patients. There have also been some other trials in the last year or two. The Vanish trial, which is valsartan. Again, this is a commonly used medication for hypertension, but it has a very nice effect on hypertrophy and fibrosis within the heart, and that seemed to be quite effective. There's the Redwood HCM trial is a kissing cousin of mavacamten, and that also looks like it's showing some positive results. And then the sacubitril mixed with valsartan and the Silco FCM trial, which is also sacubitril and valsartan, but they have an arm where they're also looking at lifestyle modification. So those all are almost done recruiting patients, and we should see some results from these trials coming out of the next 6 months to a year. So I think that there are going to be some more good options to be used. All right, but how do these drugs get from it's a great idea in somebody's laboratory to actually being able to prescribe it? And it's a fairly long, involved process. And the other thing that is important to remember is that you have the idea for the new drug, and then from the time you get that to the time that a physician is writing a prescription for it is usually about 10 years, and that's actually fairly quick. And then of those drugs, there's a huge number of them that kind of come out of the laboratory and then start making it into clinical trials. And then the drugs that actually finally make it to clinical trials, really only 1 of 10 of them actually make it out and get approved for use in the general public. And these are tremendously expensive processes to get these drugs from the test tube to a patient. And they estimate about $2.6 billion for each drug that's approved. So what's our destination? I think right now, current state, we are just trying to put a Band-Aid on the symptoms. And so beta blockers, calcium channel blockers, septal reduction therapy, a lot of these are trying to manage the results of the abnormal pathophysiology. Soon, we may be able to start intervening and preventing the heart from making that pathological change from a normal looking heart to the heart with hypertrophic cardiomyopathy. And that's where some of these drugs like mavacamten and valsartan come in and say, maybe if we treat patients early enough, we can prevent the changes that we see with hypertrophic cardiomyopathy and thereby prevent a lot of the long-term problems and symptoms and risks that individuals have. And then finally, the holy grail is genetic therapy, and thinking about trials to alter the genetics that you're born with, and could you very specifically just modify the gene defects that are responsible for hypertrophic cardiomyopathy, and then you don't have the problem and need those medications in the future. And the hope is that that will come at some point. I don't think we're a year away from that point, but hopefully in the next several years after that, we'll be at a point where that'll be part of our medicinal armamentarium. So I certainly don't want to be doom and gloom, and this is kind of a nice picture from NASA showing the sun rising over the Earth. And I think that's really where we are in the state of medical therapy of hypertrophic cardiomyopathy. And that is, we have a brave new world that we are walking into. And I think it's going to be an exciting time, and we're going to have a lot of things to offer that will help modify the disease process rather than just trying to manage symptoms once the disease becomes manifest. So thank you very much for your attention, and hope you were able to get a little idea of where we're at in terms of medical therapy for hypertrophic cardiomyopathy.
I think that was an excellent overview, and I have been speaking to some members of industry, and I have been maybe bending their ear a little bit more than they were expecting about including children in clinical trials. Obviously, we do not start with children when we can use adults to experiment on and get some good data from, and then take those best practices and bring them to a clinical trial for children. So I'm happy to say that I think we're going to see some movement, maybe fourth quarter, first quarter of next year, in opening up some trials. And I don't know, maybe some of you are going to be getting some phone calls soon about maybe commenting on those trial designs. This is my hope and intention, and sorry to make you a little bit busier than you currently are. But we need these trials done so that we can get these kids, better therapies earlier. And we are really at an exciting time. And I will pause here with a little bit of a retrospective and future thinking in the same. I feel like when it comes to genetic therapies, I feel like I did back in around 2014, 15, when a little company called Myocardia was just getting started, and they had this molecule and they had this idea and they thought it could turn into something. And I'm like, okay, this actually sounds like it might work. Now I've had other things that sounded like they might work, but this one sounded better. And the way I'm calculating it and what I'm seeing happening behind the scenes, I think we've got about a 5-year swing until a clinical trial is here in front of us, which is why we're doing the whole program on genetics to help people understand it better. So I think we're at an exciting time. We have more tools in the toolbox than we've ever had before, and the toolbox is going to get bigger. So I think you did a great job at explaining that. I don't know if anybody has any questions. I don't see anything posted yet. My whole computer just got a little wacky here. It's back now. And if we have any questions, we will address them later. Are people using the chat feature? No, they're not. Okay. Don't use the chat for questions because we're not going to follow them there. Use the question box. Balaji, you are up next, and you're going to talk about the scary topic of sudden cardiac arrest and arrhythmia management. But this is something that is completely, not completely, but quite manageable. And we'll get you started here. Everybody uses their own way. Okay, so you want to, yep.
Can you see me?
Yep, there you go. You're good to go. Thank you.
Okay, great. Well, thank you, Lisa. Thank you to the HCMA for inviting me to give this talk on this scary topic. I'm sure many of you are aware of this problem of sudden death and arrhythmias and lethal arrhythmias in children with HCM. I do have a disclosure in that I have a grant to study this from Medtronic. And I also want to put in this logo of PACES, which is the Pediatric and Congenital Electrophysiology Society, to which we all belong. Pete's been a president of the society many years ago. I was president of the society a couple of years ago. And we are very interested in this topic as well, just to mention that. So this is a slide that many of you are familiar with. It's commonly put up in pretty much every talk on sudden death in young people. And this is a paper that Dr. Barry Marin, who is again a name that I'm sure all of you, if not most of you, are familiar with, a huge name. Somebody who has published papers on almost every aspect of hypertrophic cardiomyopathy. And this one was published in 2007, where they looked at what are the cardiovascular causes of sudden death in competitive athletes. And you can see here, HCM is the most leading cause, but it's even bigger because when you look at the next one, the purple one, you see it's possible HCM. So about 45% or so of these causes of sudden deaths in young athletes is hypertrophic cardiomyopathy. And this is another paper from Dr. Marin looking at how people die if they have hypertrophic cardiomyopathy and broken up by various decades. And you'll see here that in the young people, in the younger age population, sudden death is a predominant way by which people pass away with hypertrophic cardiomyopathy. As people get older, heart failure and stroke become more important. So even though this is a very important topic, one of the problems of this discussion about sudden death is that, as you can well imagine, papers are written by leading centers that are seeing a lot of patients with hypertrophic cardiomyopathy. They tend to see the worst patients generally. The milder patients are managed locally by their own doctors, etc. And so you tend to get a sort of a skewed view of the whole condition. Now, this is a very important paper that came out in 2019 from Canada. And this is a population-based incidence of sudden death. So if you take the whole population and you look at all the people with HCM, not just the ones that showed at the tertiary care centers. Now, one of the things about the study is that it was based on the age of 10 to 45-year-olds. And based on previous publications, etc., one would expect that there would be about 704 to almost 1,500 cases of sudden death in that population, in the population in Ontario. But what they actually found was that there were only 53 cases. So the incidence of sudden death was by an order of magnitude lower than what was expected. So this may be a better slide to think of. Sudden death, even though we talk about it a lot, people who do HCM care a lot, worry about this. Nevertheless, when you take all comers with HCM, the incidence is probably much lower than what we think. And the reason for this discrepancy is probably that we've been overestimating this incidence of sudden death. Now, as you all also know, ever since the early 90s, we've had the implanted defibrillator, which can prevent sudden death. And in case you're not aware of the nomenclature, we divide defibrillators into what we call secondary prevention defibrillators and primary prevention defibrillators. If you've had a cardiac arrest or have been successfully resuscitated, and then somebody goes and places a defibrillator in you, that is called secondary prevention. You've never had a cardiac arrest or even a potentially lethal heart rhythm, and you're getting a defibrillator purely for prevention of sudden death, that is called primary prevention. One of the most important things to know about pediatrics is that we can put defibrillators in almost all children, no matter what the age. This first slide here with the tiny baby, this baby was about 3 months old. We put a defibrillator in this baby, and this slide is actually from back in 2001 or 2002. Obviously, this is the slide here shows what's called the traditional transvenous defibrillator. Most hypertrophic cardiomyopathy adults have such a defibrillator. We can place this in older children. We are now placing more and more these subcutaneous defibrillators. but you have to qualify in certain ways. Your ECG has to clear certain hurdles in order for you to be eligible for this. The defibrillator actually is also much bigger. Physically, it's a bigger defibrillator. So there are some positives and some negatives with this defibrillator. In the in-between ages or in children who are smaller, we've been using very innovative approaches like the one I showed you in the little baby, but also this is a slightly older child. I think this child was about 4 or 5 years old when we first placed the defibrillator. This defibrillator is actually done by opening the chest near the breastbone, at the lower end of the breastbone, placing leads on the outer surface of the heart. And then this lead, which is the actual defibrillator lead, is sitting behind the heart and screwed into what is called the pericardium, which is the layer outside the heart. It's not actually attached to the heart. So we are listening to the heart through this electrode. And if the child needs a shock, the shock will go between there to there. So defibrillators can be implanted at almost any age. And HCM presentation is very variable. And a very important thing is that sudden cardiac death or sudden cardiac arrest can be the first presentation in some people. Secondary prevention, that is giving a defibrillator to somebody who's been successfully resuscitated from a sudden cardiac arrest, is not at all controversial. It is very straightforward. I don't think anybody would disagree about doing this. Primary prevention is where a lot of the energy is, and how can we prevent even that first episode, because not everybody survives that first episode. So for long, we've had many questions about sudden cardiac risk in children. There was very little literature about it, and I will show you there's been some recent very huge strides made in this area as well. There were many adult papers, lots of guidelines in adults. So basically in children, we used adult guidelines and modified them a little bit. The recent guideline, which some of you might have read by Dr. Oman and company, is an excellent guideline to look at. And one of the nice things about it, which I feel very good about, is that there is a lot of reference to children and how to modify and how to look at children as opposed to adults. Now, the problem with the defibrillator is that it comes with its own set of problems. Obviously, surgery needs to be done. And as I have showed you, some of the surgery that we do is more invasive and more traumatic in children. Children tend to be more active when they are with a defibrillator. Their body size changes as they get older, and they're going to live longer with a defibrillator. All these things make certain problems worse. For instance, lead problems, which is the connection, as anybody who's old enough here to have had a hi-fi, not a Wi-Fi in their lives, knows the cables are the weak link in any electronic machine. So these leads that go from the defibrillator to the heart tend to develop problems as children get older. Children tend to have a much higher incidence of inappropriate shocks. Inappropriate shocks are shocks that happen when you don't need them to happen. The machine has made a mistake, essentially. It has looked at something, thought it'd say bad rhythm, and given the patient a shock. And this is really traumatic. People who get inappropriate shocks can develop, most of them do develop, condition akin to PTSD. And it becomes a very distressing problem, very difficult to manage. Invariably, the leads go bad as time goes by. You can have a lead that typically works for about 15 to 20 years, and then you might need to get the lead extracted. And lead extraction is a risky procedure in itself. Sometimes can be a major surgery. Sometimes leads have to be abandoned, and often leads are abandoned in the body, and that comes with its own set of problems. Obviously, I'm not talking about every single thing that can go wrong when you put a defibrillator. Now, as all of you know, we've had these adult risk factors that we look at. And what has been very helpful in adults, which is generally taken as greater than 16, is we've had these online calculators. We go into the website, we plug in certain numbers, which we derive on the patient, either from the echocardiogram or from the clinical history, and it throws out a number and it says, this is our recommendation. There has been a lot of controversy about this approach. I won't go into it, but for simple physicians like me, this is a very, very useful tool in that a lot of the thinking has been done behind the scenes for us, and the complicated equations that are used to derive these are not visible to us. We don't know what fallacies there are. We know that this is reasonably good at predicting. Using these calculators in adults, it is estimated that if you put 10 defibrillators in people in whom the machine recommends that you put them in, you're going to save one life in every 5 years. Okay, so that's not great, but it's not bad. And these adult risk factors are what we look at. Obviously, this is resuscitated sudden cardiac death event goes into secondary prevention, but extreme hypertrophy or thickening of the heart, greater than 30 millimeters. Abnormal blood pressure response to exercise. So if your blood pressure actually falls when you exercise or doesn't get higher, exercise should make your blood pressure get higher. And if it does not, that is a risk factor. Ventricular tachycardia or rapid heartbeat from the ventricles. Unexplained fainting. Family history of hypertrophic cardiomyopathy related sudden death. And presence and severity of left ventricular outflow tract gradient is a minor criterion for risk in these. This is the older guidelines. We did a study through PACES, published a couple of years ago, where we managed to collect 446 children with defibrillators. And as you can see, 78% were primary prevention defibrillators. And one of the key findings was that adult risk factors were not predicted. So children were behaving different. Whereas in adults, the left ventricular septum, the wall between the right and left ventricle, and the thickness of that septum was the most predictive. In children, it was more the posterior wall, or what sometimes gets called the free wall of the ventricle, which was the thickness of that was more associated with sudden death. And then a curious finding that we found was that those who had left ventricular outflow tract obstruction seemed to have a lower risk of sudden death. This was a controversial finding at the time, but since has been corroborated by other people as well. And now I'm going to tell you two major studies, one from Dr. Caskey's group from London, England. They collected a lot of patients, over 1,000 patients with hypertrophic cardiomyopathy, and they developed one of those calculators that is used in similar to the one that's used in adults. And now we have this online. And the good news is that it may even be slightly better than the adult one. In adults, as I said, it was one save, I think I said, in every 15. This in children, they estimate one save for every 10 defibrillators that are placed, where the calculator says the risk is greater than 6% in the ensuing 5 years. Another paper came out from Toronto. This is just came out 2 years ago. Another risk predicting model. It's again available online. And so now we have various different methods to calculate. None of them are perfect. I've had the problem, if you will, of taking a particular patient, plugging them in different calculators and getting totally different numbers. And then we are left scratching our heads as to what to do. But in some ways, we are really making progress on this. And I'm sure this is going to get better with time. One of the things that all these calculators, both the adults and the pediatric, don't use yet is the MRI of the heart. There's a lot of work going on behind the scenes, a lot of research. MRI is very good, much better than the echo at assessing accurate thickness of the heart. It can look at scars in the heart muscle, and the higher amount of scar and the more scars you have, it has been shown to increase the risk of death. However, there's not much studied in children, so there's a huge need there. So this is what it looks like. If you look at the MRI, you can see this is actually the lumen, or the actual inside the blood part of the heart here. The very thick heart muscle is here. And this white thing here is the scar that they can look at on the MRI. Just two different views of the same thing. You can see it's not very clearly demarcated. There's a lot of scar in this child's heart. This is a child of about 5 or 6 in whom we put a defibrillator, and this was done before we put the defibrillator in. Basically, these calculators also all demand that patients are evaluated periodically. in order to get these numbers that can then be plugged in, we have to look at what symptoms the patient has. We have to look at the ECG, echocardiogram, Holter or other kinds of ECG monitors. There's a ton of different kinds of monitors these days, periodic exercise testing, and MRI. If anybody with hypertrophic cardiomyopathy develops symptoms like fainting or near fainting, that's an immediate call for action. So to conclude, risk factors are different in children and teenagers with hypertrophic cardiomyopathy compared to adults. There's been a lot of progress on risk stratification in kids in the past 2 years to determine who may be at risk of sudden death. The further improvement is definitely going to happen in the ensuing years. MRI, I'm sure, will become a regular and important part of the evaluation. All patients need regular and periodic evaluation, and it should be at least annual between the age of 10 and 18. Now, I didn't talk about those who don't quite come up to that level of qualifying for an ICD, or in whom we don't think the ICD is required because their risk doesn't seem to be high. Very important that the family members and others, school teachers perhaps, for instance, get CPR training and consider getting an AED for the home so that you're not waiting for the ambulance to arrive. And shared decision-making. Obviously, this is something we are very used to doing in pediatrics. This is just a new term for what we have always done, which is involve the family extensively, because this is often such a gray area. You can make mistakes both ways, either by putting a defibrillator, and then the patient has all sorts of complications from the defibrillator for very little gain. On the other hand, you may decide not to put a defibrillator, and that could be a very bad decision sometimes. So it's a very gray area at this point, but we are making progress. So bottom line, children are not little adults, need to be treated very differently. And here is the view from our hospital on certain nice days like today. Thank you very much. I'll stop sharing. Open for questions.
Thank you, Balaji. That was fabulous. And we do have a couple of questions. I think people found the Q&A queue here so that they can start using it. Esther, and I have to say, Esther, when I first met Esther, she was a pediatric. I believe she was 8 years old when her parents first contacted the HCMA. And now she's an adult HCM transplant patient with children of her own. So she is asking the question, what percentage of children will get HCM if their parents have HCM? And okay, her showed up at 7, and she has a big family history of HCM. So what are the chances of her child having an HCM gene?
Looks like
Who
Pete
wants
wants
to
to
take
answer.
that one?
We can talk about, with these, let's say it's a sarcomeric defect. If it's a genetic condition, it would be a 50-50 proposition. Although, again, there's simple solution, not so much. And that is that there is something called variable penetrance, where the way a disease presents in one family member may be very different than how it presents in another family member. So we would say with these heritable conditions, if you are phenotypically positive for the disease, we would say that your kids have a 50-50 shot of carrying the risk for developing the disease.
Yeah, I think Pete put it very nicely. One of the great unknowns in medicine right now, we're learning a lot about genes. We've known a lot about diseases like hypertrophic cardiomyopathy for a long time. What I like to emphasize is that genes are also living in a pool of 1 million other genes and are all influenced by other genes. So just because you have a particular gene mutation doesn't imply that you're going to have the disease. So if a parent has hypertrophic cardiomyopathy and has a gene that is known to be pathogenic or associated with hypertrophic cardiomyopathy, then it's a 50-50 chance that they will pass on the gene to the child. When that hypertrophic cardiomyopathy will manifest in the child, whether it will manifest, how severe it will be, what will be the symptoms, what will be the different ways they present, etc., is very unpredictable. This is one of the problems of taking care of people with hypertrophic cardiomyopathy. So what we would recommend, for instance, is, let us say, the questioner seems to have had hypertrophic cardiomyopathy at age 7, if they have a child, we would start evaluating at the age of 7 or whenever they're present, whenever they come to us, we will start evaluating. But then we would really start looking very closely from about the age of 10. Most hypertrophic cardiomyopathy seems to happen and manifest itself around puberty. And so starting around the age of 10, we would look very closely and intensively at that child.
Excuse me, still getting over COVID here, so ignore the coughs. And if you saw me wince, I just dropped my phone and it landed on my foot and it really hurt. So I wasn't wincing over any comments. Esther, call me because you and I need to talk about something else. So awesome. So next up, we're going to have probably the most common question that I have addressed by HCM parents and even some physicians. What do we do about exercise and sports in a kid with HCM? We know kids are going to be kids and they're going to run around. What's safe? How do we keep them safe mentally and physically? And how do we do this, Christa? What are we doing? You're up next. Did she freeze? I think Christa just froze. Awesome. Great time to freeze. Just when you're up. Uh-oh. All right, let's see if we can't get her back here. Everybody else is moving, right? It's just her that's frozen. Love when this happens. It's that kind of a day, people. It's that kind of a day.
Well, I think
Right.
this is also, Lisa, one reason why Christa's talk is going to be so great. And one of the things that separates taking care of adults and taking care of children is because it's such a different animal psychologically for children and adults. And the adolescent mind, there's such a dramatic change that occurs from age 4 to 8, and then from 8 to 12, and then 12 to 16, and 16 to 20. And you get to see people in all different stages of that process as the brain matures and everything else happens. And, you know, whether it's the, you know, Balaji knows this from taking care of lots of kids with HCM with defibrillator, whereas if you were 65 years old and had 2 MIs and you got a defibrillator, you're tapping your defibrillator and saying, thank goodness I have this. I'm so grateful. This is really helping me out. If you're 15 years old and you have a defibrillator, that thing is poking you in the eye every day, reminding you that you have this condition and how unfair it is and how limited you are and how different you are from everybody else. So it is a just an unbelievable psychological burden to walk around with this condition. And I think it and not just for the kid, for the family, for everybody involved, for friends, for whatnot. And so I think that also makes it so important about this whole concept of sports, where you say, you know, who cares if you can play or not? Well, for a lot of kids, that's really one of the most important things that they're going to be doing in their childhood. And it's a very important developmental time. And I think people are starting to realize that, you know, we can't manage risk just looking at one thing. It has to expand over the entire person and family. And if you say, well, we're going to protect you from X, but we're not going to worry about Y or Z, and Y and Z may end up being a bigger problem. So
Pete, question for you. If you have a child of say 7, just like the question, and say the child has is gene positive, doesn't yet show hypertrophic cardiomyopathy on the echo, how do you tailor your conversation for the family in terms of future exercise?
Mm-hmm. Yeah, I think that's a great question. And so the conversations we have is, I usually say, look, the US guidelines right now, if you're genotype positive and phenotype negative, you can go ahead and participate fully. Whereas if you were in Europe, if you were genotype positive, you were restricted from participation. And I'd say, so you have full range, but you know, you could become phenotypically positive, and then we have to pull you out of sports potentially. And so trying to target people into different lifetime sports or sports you'd even be able to participate. You know, would you be happy playing baseball instead of basketball? Is golf an option? We're in Georgia, so, we have two sports here. We have football and we have spring football. And so it's a little bit tricky to do that counseling and try and move people into other sports for something that may or may not occur.
Yeah, there's a lot of different cultural issues that come around regionally as to what sports are appropriate or not. And we thought Christa was going to run away from the conversation. She's like, nope, I don't want to talk about this. I'm out. It's just technology, Mercury in retrograde, whatever you want to call it. We've had a lot of issues today. So you left some anticipation, but these guys
So
had a great conversation. So you're up, and thank you so much for coming back and not being afraid to.
No, I'm not afraid. I'm really excited to talk today. I'm actually really thrilled to be here. I think the HCMA is a godsend, not only to patients, but to their families and to us physicians. So
Thank you.
here. Yes, this is a really tough topic, and I'm sure a lot of what I'm going to say is probably going to be controversial, but dig in.
It's HCM. We've got to be a little controversial. We have that history, right? So
Yeah, absolutely.
why don't you do your screen share and we're good to go.
Okay. All right. Oop, hang on.
Don't log off again.
I actually didn't log off. I got kicked off. Anyway. Okay.
Who knows? Again,
There we
technology. Sorry about
Yeah.
that.
No, it's not you. It's probably my Wi-Fi. Okay. So I think I'm screen sharing. I
You
hope.
are, and we see your desktop. And now we
Okay,
got to go.
so-
There you go. You're good to go. I'm going to go away now.
So here we are. Okay, so sports and athletics. This is a topic I got really interested in when I was a first-year medical student and I first learned about HCM. And I was told that one of the treatment features of treatment was that these patients could not exercise, which just sounded like a really tough thing to have to deal with, especially as a child. So the question is it safe to exercise if you have HCM? We do have tons of information, lots of evidence that intense exercise is a risk factor for sudden cardiac arrest. We also know that young age increases mortality. So kids have a higher mortality risk, about 2 to 4% annually. We also know that hypertrophic cardiomyopathy is the #1 cause for sudden cardiac arrest and death in athletes. So the conclusions seem fairly natural to make that we shouldn't allow kids with HCM to exercise. But is that the most appropriate thing to do? It's important to keep in mind that all of our data comes from patients with previously unknown diagnoses. So these kids were not on medications. They did not have an ICD. They were unaware of any kind of risk mitigation strategies. And certainly there was a very good chance that there was no cardiac emergency response plan in place. I'd like to spend some time talking about the physiology of exercise because it's fascinating, but in the interest of time, I will just point out that as Dr. Towbin had spoken about, the mitochondria is the powerhouse of the cell. And so when you need to exercise, these mitochondria need oxygen to create ATP. And so the heart's job is to deliver that oxygen to these mitochondria. And so it does that by increasing its cardiac output. And it's a very simple formula in the upper left-hand quarter about how the heart increases its cardiac output. And it does so by increasing its stroke volume and its heart rate. So it improves its contractility, it squeezes even harder, and the heart rate goes up. And so you get more oxygen delivery to the exercising muscle. As Dr. Balaji had said, the blood pressure goes up with exercise, but your systemic vascular resistance goes down. So you're really perfusing, you're getting blood flow into those exercising muscles. And the cost, of course, is increased myocardial demand. Your heart has to work a lot harder. And if you have HCM, that's a problem because your heart can't relax as well. You have diastolic dysfunction. And so the heart doesn't fill as well. And so stroke volume is compromised. And in about half of these patients, there's left ventricular outflow tract obstruction. So there's obstruction to getting the blood flow out to the body. Some of these patients have chronotropic impairment, meaning they can't increase their heart rate appropriately. And most importantly, there's ultimately an oxygen supply and demand mismatch. So you have a thick muscle that needs oxygen. Now you're asking it to work even harder. The oxygen demand goes up and there's some small vessel disease there as well. So the heart itself is not getting the oxygen delivery that it needs. And this can lead to feelings of shortness of breath, and chest pain, as well as exercise avoidance, which is a cyclical issue because when you're not exercising, it's that much harder to exercise. But really the issue is not just can these kids exercise, but is it safe for them to do so? There's a camp of people that feel that because exercise increases your left ventricular size, that you're going to worsen the phenotype. In other words, exercise is just bad for a heart with HCM, but that's been pretty much disproven with mouse models. The real issue is exercise going to trigger a dangerous heart rhythm issue, ventricular tachycardia, ventricular fibrillation. And the bottom line is that the heart muscle, the myocytes, the cells, they're unpredictable. It is possible to have a sudden cardiac arrest even in the absence of any major risk factors. So the thinking is, well, let's not make a bad situation worse by courting danger. Let's not let their epinephrine levels increase. Let's not let them exercise because that will cause dehydration and that's going to set up a situation where they could have a sudden cardiac arrest. But we also know that exercise is medicine. Exercise is good for every organ system, especially for the heart. And so we do have some adult data that points to exercise in HCM patients. In 2015, there was a small study of 20 patients with a New York Heart Association class of 2 or 3. So just to refresh your memory, the New York Heart Association class of 2 or 3 means they're having either mild or moderate symptoms just with daily activities. And they were put through a rehabilitation program, and about half of them actually bumped up by 1 or sometimes even 2 New York Heart classes levels, which is excellent. In 2017, we had the RESET trial, which took 136 patients with an average age of 64 and divided them into 2 groups. One group continued on as they usually do, and the other group was assigned to 16 weeks of a moderate intensity exercise program. And these patients that ended up doing moderate intensity exercise had a small but statistically significant improved VO2. Your VO2 is the gold standard for how well you're able to exercise. And that is a number that we get by doing a cardiopulmonary exercise stress test. They also had improved scores on their quality of life surveys. And probably most importantly, they had no adverse effects. There were no episodes of ventricular tachycardia, sudden cardiac arrest, or sudden cardiac death. And this seems to be true for the additional 2 studies that I'll quickly touch upon, which is that there were no associated ventricular arrhythmias in the 2018 retrospective study that showed that people with HCM who continued to exercise vigorously against medical advice ended up having improved diastolic function compared to those patients who did not. Finally, in 2020, there was an interesting study published in younger adults with an average age of 31. And again, there were a group of athletes that refused to follow medical advice, continue to participate in competitive sports. And they compared them to those patients who had opted out of exercise. And actually, there was no difference in their sudden cardiac arrest risk. So this kind of came as a big surprise, and it made us all start rethinking our recommendations. Okay, so I would like to introduce the concept of an individualized exercise prescription. There are factors that influence an individualized exercise prescription. So there are certainly the HCM details that we need to know. Is there left ventricular outflow tract obstruction? What is the ejection fraction? What is the VO2? There's actually other parameters that you can obtain on a cardiopulmonary exercise stress test that will also predict how well you will be able to sustain exercise. The VEV-VCO2 slope is a good measure of diastolic function, and also the oxygen pulse. Excuse me for one moment. I'm so sorry.
I like dogs, so I don't mind the barking in the background.
Okay, I'm so sorry. I let the dog. Okay. As Dr. Balaji had said, the cardiac MRI really gives us a ton of information. So is there cardiac scar? Is there LGE on your cardiac MRI? And is there any evidence of ventricular tachycardia on the Holter monitor? We also need to take into account the personal details. How old is the patient have an increased risk for sudden cardiac arrest? What kind of exercise do they like to do? Are they symptomatic with exercise? If they want to continue in a team sport or an individual sport, do they have their coaches support? Are we talking competitive sports? Are we talking about recreational? That makes a really big difference if the patient is ready to tackle a team and is going to put that team ahead of their own health. Are they going to listen to their body? So as Dr. Balaji had mentioned, we have always been doing shared decision-making, but I feel like it's definitely become more into vogue now, thank goodness. We're getting away from the paternalistic aspects of decision-making. So this really, we're dealing mostly with minors. It's not just the patient's wishes that we need to take into consideration. It's obviously the family, the cardiologists that care for them, and the team doctor. The team doctor actually has a lot of say in this. And what is their level of risk tolerance? If we say there's a 1% chance that you could have a sudden cardiac arrest, is that unacceptable? Or is the cost of not participating in sports so great that maybe they're willing to tolerate a higher risk? There are certainly consequences of disqualification. There are physical and psychological issues that can arise. Certainly from a physical standpoint, it's not healthy to be a couch potato. And from a psychological standpoint, not exercising can certainly be associated with depression. So if you have a situation where you or your child wants to participate in sports, it's not necessarily off the table, but there needs to be a full informed consent, lengthy conversations around these issues. And if they are going to proceed, you absolutely need to get them on board with risk mitigation, okay? So they need to make sure that there's cardiac emergency response in place, whether that's at their school or at their field or on the court. An AED should absolutely be available. And as a side note, some of these kids are going to have ICDs, and Rachel Lampert and her colleagues did some really interesting research looking at the safety and feasibility of competitive sports in patients, not just with HCM, but just patients in general who had ICDs, and the results were pretty encouraging. However, I should note that just because you want to play sports does not mean that that's an indication for you to get an ICD. You really have to go back to, as Dr. Balaji was saying, what are the circumstances that would push you towards getting an ICD? Okay, so does avoidance of exercise really even prevent sudden cardiac death? I'm not going to spend too much time on these studies, but they're huge studies. Corrado in 1998, looking at over 33,000 athletes. This is a very well-known, well-cited study. Arguing for the use of appropriate screening of athletes in Italy prior to sports. And another interesting one out of the UK, where 5 patients were diagnosed with HCM. And these are young soccer players with an average age of 16. And 5 of them were diagnosed with hypertrophic cardiomyopathy. 3 stopped playing and they were alive 10 years later. 2 continued against medical advice and they did not make it. So it is a real risk. But again, you have to balance this against the potential harms of disqualification. There can be depression, loss of self-confidence, a loss of a sense of belonging. And for some of these kids, these really competitive athletes, there could be a financial hit with scholarship loss. So what can we do if our patients say that we want to go ahead and we've talked about it and we would like to participate in sports? They really should not train alone. Again, an AED should be readily available. Cardiac emergency response plan, which is a passion of mine, something that we've been working on through Project Adam, which I could talk about at a later date, is really important to make sure that everybody, as Dr. Balaji had said too, the teachers do the new CPR. And then we have to encourage the patient to listen to their body. They're going to have to put their health as a priority ahead of whatever the team or sports activities that they're involved in. And then hydration is huge. You really are putting yourself at risk for a syncope or a sudden cardiac arrest if you're hydrated, if your electrolytes are off. So that brings us to nutrition and obviously sleep. We encourage them to avoid caffeine and stimulants, and they really need to follow up on a regular basis. So from a medical legal standpoint, where are we? Well, in 2020, the American College of Cardiology and the American Heart Association updated their guidelines, and they really became a lot more liberal about exercise. So if you have the genotype of HCM, but not the phenotype. At that point, you can do whatever you'd want to do. But for patients with the phenotype of HCM, there's a class 1 recommendation, which is their strongest evidence-based recommendation, that if you want to participate in recreational, moderate intensity exercise, go ahead. A class 2B recommendation, which is weak, but still a big change from their old guidelines, states that competitive or high intensity sports should be considered after a comprehensive evaluation and shared discussion with the family and the patient and the caregivers. It's interesting to note that there actually is a legal precedent in this country for the team physician to be the ultimate decision maker. There was a case in the late 90s when I was in medical school of a collegiate basketball player who went to Northwestern and unfortunately had a sudden cardiac arrest and was thankfully resuscitated and diagnosed. He was not diagnosed with cause. An ICD was implanted and he wanted to continue playing basketball. And ultimately, through the jury and then in appeals, it really came down to what the team physician said. And so again, this was the late 90s. We were still a little bit switching out of the paternalistic practice of medicine more into shared decision-making. But I wonder what would happen today if that lawsuit ensued, if there would be a different outcome. So what do I think about the future with sports and HCM? Well, I definitely would encourage every patient, every kid, every child that wants to participate in sports or any kind of exercise to get a very specific detailed exercise prescription from their cardiologist, taking into account their preferences, their symptoms, their data from echo, Holter stress test, cardiac MRI, looking at their risk factors, again, discussing what their risk tolerance is, like how much risk are they willing to tolerate, how much risk are their parents willing to tolerate, to see if they could participate in sports or exercise. And then again, if they do participate in sports, we really have to do everything that we can to mitigate their risk. I'm also really excited about mavacamten, which has been mentioned already. We know in adults that it actually improves their peak VO2 and it reduces their VE/VCO2 slope, which is very encouraging. These patients showed improved exercise tolerance and decrease of symptoms. We don't know yet if it's going to decrease mortality or decrease the risk for sudden cardiac arrest, but as Lisa mentioned, we really need some pediatric studies looking at these questions. And a couple of other research studies that I'm interested in following. One is the LIVE HCM study, looking at patients anywhere between 8 and 80 years of age and looking at their exercise behaviors to determine the safety of exercise. And then there's also another study called the Dallas HIT study. And so that's looking at a comparison between medium versus high intensity exercise. So in summary, the myocardium of patients with HCM is inherently unpredictable. Sudden cardiac arrest is possible even in the absence of major risk factors. We know that it's a major cause of sudden cardiac death in previously undiagnosed athletes. Sports restriction absolutely can help prevent sudden cardiac arrest, but we need research so that we can help these young people and their families make evidence-based decisions regarding their risk for sudden cardiac arrest and what they're willing to do. And again, this is a shared decision making scenario with really personalized exercise prescriptions per patients. Thank you.
You are very welcome. And I absolutely love, and I just had a deep conversation with Jeff Towbin and his crew down at Bonheur about this very issue. Exercise prescriptions are not used enough. And I would love to see, hint, hint, nudge, nudge, my researcher friends here. I would love to see some trials providing exercise prescriptions, not only to the child, but require the parent be there to watch and learn and see what it's like for them to be short of breath and it's okay. And have some training from the nurses to guide them through, this is normal, this is too much, and help these kids learn how to work with the only body they're ever going to have.
Exactly.
And if we can bring everybody's anxiety level down a little bit, and I'm not suggesting that we have these kids out there sprinting, I'm talking about teaching them how to safely exercise, how to use gym equipment, how to stretch, how to be a healthy human being. I was 12 years old when I was diagnosed. And I went from being the fastest kid at age 10, 11 to the slowest kid at age 12. And then it was sit down, don't do anything. Psychologically, that messes with you. Physically, people don't understand that you can't do as much as other people, but what can you do safely? So I would like to ask for a exercise prescription for patient and parents, plural, not a parent, both parents, so that mom and dad are on the same page, whether they're together or not, everybody understands. And yes, I want exercise prescriptions. And then I want them reimbursed, and I want them paid for, and I want your time paid for, and I want a lot of things. But do you think I want something reasonable, Christa?
Absolutely, absolutely. And I don't think any of us, well, I won't speak for everybody, but I think at least I can speak for my colleagues and the colleagues that are here right now. None of us went into this for the money. So you're right. We're not going to get reimbursed for our time, maybe one day, but that's not what's important. I think what's important is giving these kids the quality of life that they deserve.
Right. Balaji, Peter, anything here? Those magic mute buttons.
No, I think that was, Christa just basically nailed it and kind of came up with all of the kind of key points. And these conversations are fraught and it's hard. I think we as human beings are very bad at risk assessment, and it is hard to kind of have that conversation. And I find these office visits turn into an hour, hour and a half long visits, and the parent and child are with each other 24/7. We see these kiddos for an hour once or twice a year, and so it is hard. And then when you're 14 years old and you're playing, I remember having conversations with patients who say, well, you can't play competitive sports, but you go and play basketball in the backyard with your brother. And I started thinking, man, when I would play basketball in the backyard with my brother, those were blood sports. I mean, that was, no holds barred and everything. And so you wonder, is that even more risky? But I think letting people have some autonomy and trying to have the discussion that it's a healthcare team and the physicians on the team, the parents are on the team, the kids on the team, everybody's on the team. And unless everybody's rowing in the same direction, the team doesn't work. And that means that at times the physician's going to have to compromise, and no one's going to get everything they want. But at the end of the day, we have to all be invested in what is the very best thing for the kid. And sometimes taking extra risk is the best thing for the kid.
Talking of things that need to be paid for, I think one of the most important things that needs to be paid for is AEDs for families to have in their home. Currently, insurance companies will pay for a $25,000 ICD, which goes into the body. I mean, that's just the ICD cost, not the whole cost. Mm-hmm. The surgery, etc., costs a lot more, but they won't pay for a $1,000 AED that people can have in their home. And it could potentially save multiple people, because obviously HCM may not be just one person in the family living with HCM. So we've written a strong editorial / opinion piece on that. Hopefully it'll get published soon. But I think we in the community, both HCMA and also physician community, need to be pushing this very strongly.
It's an excellent point to bring up to our legislative advocacy committee. And we're doing a deep dive on some areas of reimbursement. That is one. Another is, cardiac rehab after myectomy for children and adults. While it's much more rare to have a myectomy as a child, rehab isn't covered unless the mitral valve has been touched. What? Like, that doesn't even make any sense. And sometimes you can scooch it in, but sometimes you can't. We need a consistent policy there. I want to take a moment here to kind of talk about some of the unusual things that I've seen with regards to student athletes and parents making decisions. And the concept of shared decision-making, I'm all in on. But, and there's a big but here, making a decision for my own health is very different than making a decision for my child's health. And having my child trying to take autonomy when their brain is not fully functioning yet because they're not an adult yet, well, that's a whole other story. So I want to share a cautionary tale, and for purposes of anonymity, I'm going to change the sport and I'm going to change the location in the country. But child in late teens gets diagnosed with HCM. Child is very active in a sport, we'll just say it's soccer, but it wasn't. And child can no longer play on the school team. So soccer is his life. He wants to play soccer. He demands to play soccer. So parents say, okay, let's put you on a club team because the club team doesn't require a physical. This young man died on the pitch, we'll just call it. He's out there on a club team and he drops dead in front of a coach who had no knowledge. The team had no knowledge. This kid kept it quiet and the young man died. The parents must live with the consequences of that death, which are devastating. But everything kind of went wrong here, in my opinion. You can't send your kids out to play a sport and not tell the adults what's really going on. Yes, sudden death is rare, but when it happens, you need somebody to respond. You need that AED there. You need compressions to start immediately. You need an emergency response plan activated, not holy crap, what's going on here. So shared decision-making, get it. I want it. I want it everywhere. But athletics and shared decision-making, slippery slope, controversial. We don't want kids sitting down and doing nothing. And we don't want them doing more than their heart can tolerate. And we certainly don't want it done without a safety net of some sort.
That is such a great example you brought up because that's actually really not shared decision-making. I think shared decision-making absolutely has to be completely predicated on truth. There has to be trust, right? That the parents can tell the cardiologist, this is what we want to do. The cardiologist has to be savvy enough to recognize that if they have a kid in front of them that's like a diehard athlete, that they need to work with them to figure out what they can do. Maybe they can be the team manager, maybe they can do a club sport, but again, risk mitigation, right? Everyone needs to be on the same page. I agree.
I also think, there are limits to shared decision-making. Any good doctor knows this. There are some patients with whom you have to be pretty firm in what you say. And then there are some with whom you can be really, this way, that way, and you go into lots of nuances. Some people can tolerate nuance. Some people absolutely cannot. They want it black and white. And then they want you to be black and white. And then you have to be black and white. You can't, it's funny. Yesterday, a patient that I saw 3 years ago, not hypertrophic cardiomyopathy, but a sudden death syndrome. I saw him 3 years ago and I cleared him for sports. And I had a virtual visit with him yesterday. He comes on the phone and he says, I can't do a virtual visit, but I can do a phone visit. Can you talk to me on the phone? So I said, okay, I'll talk to you on the phone. And this kid, he's 15, he's coming on the phone, no parents around. And he says, can you give me a letter to say I can participate in sports? And I said, well, I haven't seen you in 3 years. And he says, but you saw me 3 years ago. Why can't you give me one? So teenagers are just the most interesting people. They have no idea of reality sometimes.
No, they know everything. They know everything. You know nothing, right? We were so smart when we were teenagers, and then we grew up, and then we got less smart somehow. So it gets challenging. We are going to go to our pre-recorded portions now, and we're going to hear from Dr. Shari Jefferies, and we're going to hear about mental health implications of hypertrophic cardiomyopathy in teens. I'm going to give this a little bit of a warning. Julie, you're ready to go up in a minute here. This might be a topic that some of our viewers have never quite delved into like this, and there is some information here that can be a little upsetting. We're talking some statistics here about depression, anxiety, suicide in patients with serious cardiac issues. It doesn't mean some of these risks can't be mitigated, but we have to start having some tough conversations. And that's what we're here to do tonight. So Julie, you want to do a screen share? And let's get going.
Hi, my name is Dr. Shari Jefferies, and I'm here tonight to speak with you about psychological well-being of children and adolescents with hypertrophic cardiomyopathy and medication management. In looking at the numbers, in general, the number of children and adolescents with mental illness has been increasing. Since COVID-19, the numbers are skyrocketing, and we're just still beginning to understand the impact that the last couple of years have had on kids' psychological well-being. But it's estimated that 1 in 6 children aged 2 to 18 had a diagnosed mental, behavioral, or developmental disorder just a few years ago. Ever having been diagnosed with either anxiety or depression among children ages 6 to 17 years old increased from 5.4% in 2003 to 8% in 2007 and 8.4% in the years 2011 to 2014. Speed ahead to the years 2018 to 2019, and among teens aged 12 to 17 years old, 15% had a major depressive disorder. 36.7% had persistent feelings of sadness or hopelessness. Nearly 19% seriously considered attempting suicide, with close to 16% making a suicide plan, and 8.9% attempting suicide. This is in the general population, and this is not dealing with kids with chronic medical illnesses, and this is before COVID-19. So this is probably an underestimate of what's really going on in the world around us today. So the question becomes, how does a chronic illness affect children and adolescents? There are not many studies, but a few recently are beginning to shed some light on the effect of congenital heart disease on mental health. In the past, several of the studies would group children with chronic illnesses together. So you might have a conglomerate of children with diabetes and seizures and cardiac disease and other chronic illnesses all together. And we're only beginning to look at individual disease states and the impact on mental health and quality of life, which will be very beneficial in the future for treatment plans and for improving outcomes in these kinds of patients that have specific disease states. A study published in 2020 found that children and adolescents with congenital heart disease experience significantly higher levels of anxiety and associated constructs compared to typically developing children and adolescents. Another study published in 2021 found that youth with congenital heart disease of all severities have significantly higher odds of anxiety and or depression and ADHD compared to those without. We also have seen studies come out that talk about learning issues, learning disabilities might be increased in this population. So we're beginning to understand a little bit better, but looking at specific disease states will help treatment teams and families not only plan, but also treat for better outcomes physically and emotionally. Why is the diagnosis of hypertrophic cardiomyopathy impacting children maybe in a different way than other disease states? And I think it's because there are some unique and common traits that are shared among some of these disease states. Specifically for children with hypertrophic cardiomyopathy, the adolescent sense of freedom and independence is interrupted. And so typically developing children begin to choose their identity, they choose to figure out who they are, where they want to go in life, what they want to do, who they want to hang out with, and they also start being more autonomous as they get older. However, when you are dealing with a chronic illness, some of these things are abruptly stopped or they are prematurely delayed. And so looking at how to empower a child and how to give them some freedom and independence can be difficult when you have physical or medical restraints. One of the things that I have found to be very helpful is allowing the teenager to be part of the treatment plan as they get older. Some of the school-age children that can understand are also, I think, an important part of the treatment plan, and being able to actually have ongoing conversations and ask questions, not only, quote, letting them be heard, but I have been amazed at the insight and perspective that these children and adolescents can bring to the treatment team. I have been in many meetings where a child will ask a question that no one on the treatment team has even thought about, or a teenager might have a solution or a strategy to try that we had not come up with on our own. And so not only is it just validating the feeling, but it also can be very beneficial for the treatment team and the family. Another thing that contributes is if someone has an identity as an athlete, if that is taken away, that can be very devastating. Providing other avenues to stay involved with sports or activities that the athlete loves is very important. The limitations of physical activity that have been placed on several of these children once diagnosis is made can affect daily life and is just a constant reminder of the disease. Taking your medicines and being compliant is obviously going to be very important. And so a lot of times I'll get a referral for someone who has a chronic debilitating disease, and it is very important that they be compliant with their medications, and the child is not. And oftentimes these are teenagers. And when we actually talk with them, or when I have a one-on-one conversation with them, what really comes out is that having to take the medication is just a constant reminder to them that they're different, or a constant reminder that something is not right with them, and it doesn't feel good. And so it had nothing to do with them being oppositional or defiant. It had everything to do with just wanting to kind of be just a normal kid, wanting to kind of do the other things that their friends were doing. And unfortunately, some of that gets stripped away when you get a diagnosis. Something that is obviously very unique to this disorder is the risk of sudden death. And is there a need for a device? And all the kind of questions that you want specific answers to, but that nobody has a crystal ball for. And so by educating, you can empower, even if you don't have all the answers. There was a recent study just published in 2022 looking at patients with hypertrophic cardiomyopathy and an ICD, and it showed that they did have a measurable degree of anxiety and depression-related symptoms and physical limitations that were affecting their daily life. And so this is not something that you just have to think about once, every once in a while. This is with you constantly, all the time, and it impacts anything and everything that you do, and it impacts the entire family. And so managing parental anxiety is very, very important. Having that conversation with yourself as a parent or with a friend who is a parent, giving them the okay to feel overwhelmed, to feel stressed out, but taking a step back to assess and getting help if needed. There are some different forums. One was WeChat that provided a lot of support for parents, and they did a study during COVID looking at families that had kids that had surgery for congenital heart disease, looking at them during the pandemic and the amount of support that they got with the WeChat. And it did show there was some significant reduction in the burden and the anxiety that the parents felt. So it is not to be underestimated, the power of support group and the power of having other people that understand what you're dealing with, and that you can just sort of vent and get it out or come up with ideas and support one another. And then isolation from peers. Everybody thinks, oh, well, it's just, you can't participate in this sport or that sport, but it really can be so much more than that. It might be not being able to go on certain kind of field trips or participate in certain kind of activities, not just sports related, but other activities. But it could also be isolation from you miss something important at school, or you get behind at school because you had an all-day, evaluation, or you had to have a procedure. And so providing support groups, whether it be in person or online, can be very important for teenagers and be very protective. Acknowledging the difficulties is probably one of the number one things. There was a study that looked at athletic adults with hypertrophic cardiomyopathy, and over 50% did report stress and difficulty adjusting to the exercise restrictions. This is not just giving up the activity itself. It's what the activity represents. It's your routine. It's where your joy is. Oftentimes it's your social interactions. Long-term effects such as weight gain or always being worried about the safety of the exercise were definitely there. But the one piece that sort of popped out to me was the one bit of good news was that a unique form of social support by having family and friends participate with you in lower intensity exercise or activity was very beneficial. Lack of understanding from this same group was detrimental, but by getting involved and everyone participating in it together really seemed to provide some insulation and provide some psychological support. So how do you help? Again, adolescents benefit from being part of the conversation about risks and treatment, and each child is different. I always encourage people to be honest, but be also just factual. You don't have to elaborate. You can answer the question and then move on, and you can say, I don't know, when you don't know. Education begins early for the whole family, and so not being condescending, but taking time to really explain to people what's going on, what you know, what you don't know, where future trials are going, where research is headed is very important. Managing parental anxiety. And with that, one of the studies, and it's really small, and I apologize for the way it came out on the slide, but there was a specialized camp for kids with cardiac defects, and it was very beneficial. And what they found was it was beneficial for a couple of different reasons. One was that it provided new experiences, typical kind of new adventurous experiences for these kids, but it also provided some parental separation, which a lot of the families struggle with, because having people that are qualified to watch your child that you feel safe with is very important. Again, support groups like WeChat, have to be careful with kids online. That's a whole nother conversation, but making sure that it's done in an appropriate forum, but that they have some support from other kids that are dealing with the same struggles and issues and questions that they have. And then family and friend support for lower risk activities can be very beneficial. The bottom bullet is to screen a patient's mental health at appointments and at follow-ups and treat if needed. So you have to have the conversation, and it has to be evaluated as just any other kind of typical question. We got really good in pediatrics of saying, do you wear seatbelts? Does anybody smoke in the house? Are there guns in the house? Maybe we also need to say, how are you adjusting to the diagnosis? How can we be of help to you? Are you getting some of the support that you need in your own community? Those are standard questions that hopefully are part of a lot of the treatment plans already, but that definitely could be integrated very simply into treatment programs. So what do you do if you think that you have anxiety, depression, ADHD in your family? If your child has it, the first thing is getting a good assessment. Knowing what you're dealing with is very important. Having the professionals in a multidisciplinary clinic, or having the professionals speak one-on-one with each other so that everybody's on the same page is very important. Having families have realistic expectations. One pill does not fix it. And so typically a combination of medication and therapy is the most optimal treatment if medication is needed. Along with this, though, people need to be vigilant, look for changes in behavior, changes in your child's normal day-to-day activities, changes in sleep patterns, appetite, activity, involvement, isolation are all very important screeners that need to be looked at sort of on a day-to-day basis with all children, but specifically with kids that have the extra concern of managing and dealing with a chronic illness. So when the evaluation is being done for medications and the diagnosis has been made, medications may or may not be part of the treatment plan. The American Academy of Pediatrics, American Heart Association, several others have put out statements saying it's prudent to carefully assess children for heart conditions. Most of the families that are listening tonight have already been diagnosed with these, so I will just talk kind of briefly about these. But in a general population that has not been diagnosed, a patient family history focused on cardiovascular disease risk factors is very important, along with a physical exam and any follow-up that is recommended by the physicians, which may or may not include EKGs, etc. There needs to be special attention paid to blood pressure and heart rate. Some of the medications for ADHD, depression, anxiety can affect these parameters. There are certain classes that are contraindicated, such as the tricyclics, because of their effects on arrhythmias. There are certain SSRIs that seem to be better than others, although in general they have relatively minimal cardiovascular effects as long as they are monitored appropriately for follow-up. Alpha-2 adrenergic agonists can affect heart rate and blood pressure and cannot be abruptly discontinued. Sometimes they can have a rebound hypertension if discontinued abruptly or not taken as prescribed. And for the families that are dealing with hypertrophic cardiomyopathy, probably the number one thing is looking at drug-to-drug interactions, because several of these medications are metabolized by the same system within the body. And so that's very important for everybody to be aware of what medications patients are on and how to best monitor them. Questions to be asked. This is again in a general population that we were seeing for the first time, evaluating medications. I would be asking about symptomatic cardiovascular disease. I would also be asking about family history of sudden or unexplained death, particularly in young people less than 35 years old. And again, asking if there has been a diagnosis of any other arrhythmias, hypertrophic cardiomyopathy, or any other abnormal rhythm condition or event requiring resuscitation in a young member of the family. So this concludes my presentation. We've glossed over a lot of information, but I just want to encourage you. There is no room for don't ask, don't tell. Clinicians and family members must talk about mental health, and this is going to be an ongoing conversation that spans over years. If help is needed, there are resources. I've lifted 2 websites here that people can go to. There's Facts for Families and where to find clinicians close to you. If medications are indicated, get a good evaluation, weigh the risk versus the benefit, start low and go slow, and be compliant with good follow-up, providing ongoing support. I've listed some reference articles, and I thank you very much for your time. Hi.
Okay, Julie, you can pause that one and everybody can come back with me. I felt alone there for a moment. We're back. I thought that was very insightful and there was a lot of information there, and I'm going to suggest some rewatching of that particular segment and kind of breaking it down into its pieces because we went through a lot there. I will say this in a full disclosure moment. So as many of you know, I was a kid with HCM myself, and then I had a kid with HCM. And my daughter has some challenges with anxiety. And she also had an inappropriate shock of her device at 13. And she had to have a device at 10 and a device at 13 and a replacement lead. And it left some PTSD behind. So there's nothing to be ashamed of in talking about mental health issues. It happens. These are tough issues. I probably at that age, in those younger years, had a little bit of PTSD, but I didn't know what it was or how to process it. 1 or 2 people that I know here were around me at that time. Full disclosure, Julie, our volunteer coordinator, and I have been friends since we were like 10 and 11. So she was there the day I got diagnosed. So she saw it. It's real. It's a very anxiety provoking time. There's a lot going on. There's a lot that kids shouldn't have to deal with, but we do. So to talk about the mental health aspect with your healthcare providers, with your cardiologist, with your primary care physician, getting a therapist in not only for the child, but for the family. It's a big coping issue. We have a number of families who maybe the older child is very athletic and is going to be varsity level, and the other child has HCM, and that's not going to be the pathway, but they have to watch the other sibling participate in things that they can't do. There's so many places to get kind of wrapped up here in the psychological. Docs, what do you think?
Lisa, I have a question for you. In your youth, as a child and teen, and I understand it was in the 1920s, so things were different.
The Yankees comment came back to bite me in the butt. Okay.
Forever. But did your physician at that time address mental health issues, number one? I know that in the clinic, even the phenotypically negative kids, after I make a diagnosis, I beg them and the family to get into therapy. And I would be interested in hearing from you and also the families who are here about what their opinion and do they feel that it is good, bad, or indifferent when the physician is really pushing for some kind of mental health visit, even in a kid who appears well-adjusted.
So I will start by saying the year was 1979. The comment I was given at the confirmation of my diagnosis was, you have what runs in your family. They called it IHSS at the time, idiopathic hypertrophic subaortic stenosis, pronouncing it was a challenge at 12. And the information that I was given was you could die suddenly at any time. Nobody could really do anything to help you. CPR probably won't bring you back. And that was the end of my consult. So I left thinking I could die at any moment. So let's be real here for a moment. I'm 12 years old. It's me. I've been like this all my life. So can you imagine me at 12? All right. Christa's going, oh God, what would that like? Ask Julie sometime over a bottle of wine. She'll tell you all about it. But my first question to him was, well, then why do I have to do my homework? I'm going to die anyway. And that was my mindset for about 4 years. And I could have been more destructive. I did not like alcohol, tried it early, made me feel terrible, didn't go that path. New drugs would probably speed up the process of death, but it was available to me. And thankfully I made wise decisions there. Psychologically, I didn't give a damn about anything. I wasn't even nice to some of my friends because why bother? Because they got to do things that I couldn't do. So I was a little snarky. And mentally, nobody ever suggested therapy, ever. Even after my sister died and I was 8 months pregnant and there's all this trauma going on around me, I got the kids into therapy because they had just lost their mother, but I didn't go myself for a long time. I finally did go, but nobody ever talked about the mental health challenges. Nobody talked about emotional wellness. Nobody talked about self-care. And that was a mistake. It was a catastrophic mistake. So what do? I raise a daughter who just graduated with her master's degree, who will become a therapist. So I have one in the house and she wants to focus on children and adolescents with chronic illness. So I've contributed to the cause in a different way. I'm going to ask Amy if she wants to comment on this at all.
Yes, certainly. So I was diagnosed myself at age 5. My mom passed out driving a car. Luckily, no one was hurt. We knew we had heart problems in our family, but she was officially diagnosed when I was 5. And then they happened to know enough where I was living that it was a genetic condition. So I was screened. I was found to have it very young age. So for me, at that age, it was always kind of my normal. And because of that, I think I coped okay. However, what I would say is that when symptoms hit me, which was when I was a teenager, that was very different. I played in the basketball team. I wasn't given much advice about exercise or any suggestion of mental health, help or anything like that. But things happened when I was that age and I had to quit playing basketball and it absolutely devastated me. I had no emotional support, didn't see anybody. And then fast forward again, my first child, I'm not going to say too much, was also diagnosed with quite severe hypertrophic cardiomyopathy as a baby. And he's been through the whole thing with having an ICD at a young age and having a myectomy that did not go very well. He hemorrhaged. We nearly lost him. He was on dialysis. He's okay now. But we were never offered any kind of counseling. We kind of had to pick up the pieces afterwards and we're still picking them up. And years have gone by. We're talking 10 years. And I think it's permanently, not having the psychological support in place was a huge mistake. And I don't think that, there's definitely permanent damage there. I think it can be helped. And I just think that going forward for holistic care for children, adults diagnosed with HCM, any chronic illness, that should be part of it. And it would help very much if I'm also a transplant patient, even in my transplant team, I said, who do you guys have? Who do you use, for psychiatric care, or can you recommend a counselor? Nothing. And that's recent.
Can we make that part of being an HCMA center of excellence?
That is an excellent point, Christa. Thank you for stepping right on into the train that was about to hit y'all. So we have been aggressively going after better mental health services. And we're kind of going forward with it, but we're going to go backwards again. Now, I know Westchester has an entire behavioral health center right on campus with you, but we're not tapping into any of those resources. And that's a mistake. And we need to correct these mistakes. You know, we evolve. We evolve in cardiology. We evolve as human beings. We evolve in our understanding of the world around us. We've all just been through some major, major stuff the past 2.5 years. And we have all had to take a moment and go, am I okay? Like, this is really weird. Now, on top of that, add in, I have a disease that does wonky things like try to kill me, like have arrhythmias. And what if I can't get to a doctor? It just made us that much more vulnerable. And there's been, the HCMA has had to kick up its services to be responsive to the, you know, you think you have a lack of control because of COVID restrictions and you can't get to your cardiologist and you're feeling palpitations and you're getting nervous and the adrenaline is just drilling in and your kid's sick and you're sick and you've both got HCM or multiple people in the family. There's been a lot of stress. So we are asking that every program take a moment to evaluate what they are doing to meet the mental health needs. Now, you're cardiologists, you're thinking down here, you're in the chest, but it's attached to everything else. And we need to bring in those other practitioners and figure out a way to assess these patients, make sure they're getting the services that they need. You know, this goes to adults as well as children. We have had adults commit suicide. We have adults with, and children with addiction issues. They're hiding from their problems. We're self-medicating. We can't do that. We have to face something that nobody really wants to face. You know, this thing, this vessel that we're here in is fallible and nothing is guaranteed, but we can do the best that we can with what we have and take the precautions that we need to and ask ourselves every day, what is it that I plan to do with my one wild and precious life? And go out and do it. So it's this balancing act, but I think we need to be real and accept the fact that we all need to deal with this. I will get off my soapbox now.
Well, let me
Mary
ask,
Oliver quotes help everybody.
yeah, well,
No,
let me ask Balaji, because I looked at your map at the beginning of the presentation, and there's a little red dot up there in the Pacific Northwest. And so I'm guessing that the average patient that Balaji sees has driven 2.5 plus hours to see him. So I'm going to go ahead and guess that you don't know all of the mental health providers in Salem, Oregon, or points outward. So, and you know, we have the same thing in Atlanta where we're taking care of kids from the entire state, many of whom live 4 or 5 hours away. And so we are reliant on the local pediatrician, and I feel terrible about this, saying, ask your pediatrician for what the resources are in your community. And it is part of every one of our visits. But, you know, I will now turn the tables on the HCMA, who has asked us to put a research study together. You know, how can we get a listing of providers, you know, in the region, 1 or 2 now with telehealth and everything else available? Is there an opportunity for HCMA to have?
so we have just put some new resources on our website, that there is a national hotline for mental health and substance abuse. And anybody can call that number 24 hours a day, 7 days a week, and they will provide you resources in your community to help with mental health and substance abuse concerns. I'm not going to tell you it's going to fix every problem, but they have resources for the uninsured, the insured. They have support groups. They have practitioners. They have substance abuse programs. They have smoking cessation, diet, exercise, food addiction. that's a whole big issue, especially with adolescent girls. They can't control their heart, so they try to control their food. And we have a lot of eating disorders in HCM. And I mean, it's not that it's just HCM, it's chronic illness and it's a control issue more than anything else. So when we're talking about mental health, it's the whole spectrum. It's from smoking to what you eat to, bipolar. There's kids with bipolar disorder and anxiety, and they all need to be managed, and they all deserve to be treated as a whole human being. And we are trying to do more in that area. Thankfully, we have some new programs that we're working on. I've got lots of projects up in the air, but that brings in additional funding so that we can put resources to developing these out, including some new patient services programs that we're going to hopefully be launching in Q4 or Q1. So we're there with you, and we're not just throwing it on you. We have our discussion groups. We have online communication through our Facebook communities where we're constantly providing support. But it's not mental health support, it's peer support. We need that other level, and we know it. We know it.
I also think I just wanted to mention that through my own experiences, especially now in the last few years, there's such a shortage of qualified mental health professionals, and that does not really help the situation. And the other issue that I think we really need to kind of figure this out so we can treat patients holistically. But the other issue to mention is there's a lot of kids with ADHD and autism who need medications that might be contraindicated. And we've had that in our family. I have one kid with ADHD and hypertrophic cardiomyopathy, and I have 2 other kids who are genetically positive, and 1 kid I don't know about yet because our gene is unknown significance. So there's a lot of work to do in this area. And I think that we're reaching new heights, and this is part of where we need to go.
Couldn't agree more. We are going to hear one last talk, and then we can have a conversation. Oh, Balaji, I'm sorry, you wanted to say something. I'm sorry.
I
can hand up.
I can
Okay.
wait if you want.
Okay, so we're going to pivot here. Thank you, Julie, for posting that in the chat. The National Mental Health Month post has the link to the national resource, and we'll send that out to our faculty as well after the meeting. We're going to hear from John Lynn Jefferies next, and he's going to talk about transitioning from pediatric care to adult care. So we kind of started with babies, and now we're going all the way up to transitioning care. And then we'll take your questions and stick with us a little bit longer. We're wrapping it up here. This is a big session, so thank you for sticking with us. And Julie, you want to do screen share and give us John Lynn? Fantastic, thank you.
Hello, John Jefferies here. Thank you for the opportunity to speak today about transitioning from pediatric to adult care for hypertrophic cardiomyopathy. Complicated topic, but hopefully we can provide a little bit of insight. So we know transitioning from pediatric medicine to adult medicine happens all the time. And most commonly, we would see that where most pediatric patients, if they're followed by a pediatrician, ultimately do transition to an internal medicine provider. Now, sometimes folks that are followed by family practitioners, they may be followed longitudinally, but for the most part, there is some sort of transition period. And we need to think about that and leverage that for how we might use that for our particular discussion. It's important to anticipate this transition, and it's something that if we plan ahead, we can do really well. And importantly, some hospitals and practices and providers actually require transition. And this is most notably probably a part of people's insurance policies, is that oftentimes they do have to move into adult facilities. And we see this is at pediatric hospitals, children's hospitals, where they do have an age cutoff. And sometimes there are special provisos for patients, but oftentimes they do have to be moved over. But this can be done successfully, but it does require some teamwork and some coordination. Some of the key differences in my mind, and we can talk more about this either during this get together. We can obviously always talk offline. Most of you know how to find me. Is that there is some inherent different approach to care in adult medicine, pediatric medicine. Adult medicine really does typically require more ownership at the level of the patient, and so there are more expectations. So you do assume more responsibility as an adult, or as you along with your family and your caregivers. But one of the important considerations that I would say is potentially a good thing is that there's much more evidence when it comes to adult hypertrophic cardiomyopathy management than pediatric cardiomyopathy. The guidelines can be used, which oftentimes are more informative in management. Pediatrics, we have ideas, but they just aren't vetted as much with peer-reviewed, published information, and that's just a matter of fact. And there are newer therapies out there that are approved in adult populations, which could be used now once you're an adult, that, remember, don't have a pediatric indication yet, and that would be in the form of mavacamten, which many of you have heard about. We're working to try and maybe do a pediatric investigation, but that'll be a few years off. So remember that the opportunity now to get access to this medication, unless it is part of some study protocol, is going to be as an adult. And so I think one way to sort of bring this full circle is to think about, well, what do we do when it comes to guidelines? And as some of you know, we have participated and written some ideas about pediatric hypertrophic cardiomyopathy management, but this is really kind of the gold standard. These are the AHA-ACC guidelines for the management of hypertrophic cardiomyopathy. You can access these. You can get these on the HCMA website, but I think they're important to look at just to give us some ideas about how do we look at pediatric patients and adult patients differently. And in this document, if you search for the word pediatric or child or anything, it occurs very infrequently. So that tells you, once again, that the body of literature isn't quite as robust. But these are some of the differences that I think will give you a little bit of an idea of maybe some of the change you see in the adult world. And some of these are just simple things like, what is the frequency of investigation, like interrogation with imaging? And you can see here for pediatric patients who do it every 1 to 2 years, but it's a little bit different interval if you look at adults, for example, looking at maybe every 3 to 5 years. I think some of us have our own thoughts how this could be modified in particular patient situations, but all in all, this at least gives you some idea of how to approach things. Another important component is, how do we decide about sudden death risk stratification, right? And you all have heard about this, and from myself and Dr. Towbin and other people as well, about how do we look at this in pediatric patients. It's a little more complicated, and this gives you some idea. So these are traditional risk factors that we leverage on primary prevention strategies and for implantation of ICD. And you can appreciate in these, a couple of these, we talk about massive LVH, which is up at the top there. How do we define massive LVH? Well, in pediatric patients, we use a thing called Z-scores, which are sort of iterations on standard deviations, if you will. But that goes from a thing using Z-scores as a pediatric patient to an absolute cutoff in an adult patient. So very different line in the sand, if you will. And then if you look down second to the bottom, this idea of looking at cardiac MRI, and can we leverage things like scar burden? And the answer is we can. And we do that. Sometimes it informs some of our decision in pediatric patients, but it's a pretty clear delineation in adult patients exactly what the burden is, what the cutoff point is for when we decide we think that's an important risk factor. And this is how this translates then obviously into when we decide things like ICD implantation. And here there is some mention of pediatric patients or children, but once again, not as heavily mentioned or leveraged in the guideline statements. So this transition from pediatrics to adults does have some opportunities in my mind to potentially better inform care, better clarify care. And we haven't done a good job at this, to be completely honest, and I think this is something that we could work with through the HCMA and others about developing more of a transition care statement. This is something that we contribute to, which is up to date, which a lot of providers across the world use to help to understand patients and management, and we help develop this content. And I was looking at this recently, and we really didn't mention transition of care. And this is something that I think will go back to the up-to-date editors and suggest, or at least I know in our next iteration, we will include something about that because it's going to be really important. So when I think about what we do in cardiology, who does transition of care well, or who has a plan? And I would say the one place that we've given this some thought is in our congenital heart population. So when you have congenital heart disease, most common birth defect, right? Born with congenital heart disease, you oftentimes may undergo surgery or some sort of intervention to potentially intervene on that disease or palliate that disease. And then you survive. We've done very well with that over the last few decades. But now you go from pediatric medicine, which is truly pediatric cardiology when you talk about congenital heart disease, and moving into adulthood, who's going to take care of those patients. And it's a complex topic, and an entire field of cardiology has been devoted to this. There are some statements out there that sort of provide a framework about moving from pediatric cardiology care to adult congenital care. And I think the statement has some similarities and parallels to what we talk about for hypertrophic cardiomyopathy. And I would argue we could leverage some of this information to better inform how do we transition pediatric patients to adult patients. And as you know, you'll have access to these slides. I know some of this is a lot of information to digest in a short period of time, but I think this really gets to the idea of how do we look at the social determinants of care, things like your environment and your health care and your economic stability and your education and your social and community context. All these things are really important. And if we don't address all of them, as you can see, this might lead to a poor transition, which is an important component of consideration. So how can we avoid that? And then lastly, this idea of transitional care, some key principles and guidelines. And I think some of these things are really, really important that I think we should talk about in this forum and something to perpetuate in a discussion moving forward. One is the emphasis of patient self-management, this idea of self-advocacy, because it is going to be important. Many of you have been going through this journey with your parents or your caregivers, and in some ways they may start to transition over time. So how can you become more of a self-advocate? Understanding more about your condition, building on your medical knowledge, acknowledging some of the things that are a part of all of this disease with hypertrophic cardiomyopathy. As you know, that those that live with this disease, there are non-cardiac components, right? And other things that you have to consider that impact your lifestyle. I think understanding the diversity of this population is really, really important. And that's something that we should pay more attention to, and that helps with a better transition. As you've heard from me and others, remember, hypertrophic cardiomyopathy does not obviate you from the other common things that we deal with in cardiovascular medicine, like hypertension and coronary disease and atrial fibrillation and all those other sorts of things. So a healthy lifestyle is going to help you to avoid developing those other common conditions. So just something to consider when we think about all of this. Ideas about health equity, which is I'm a huge advocate for. All these things that we must remember when we talk about appropriate care. So how can you deal with this? And I think one of the things that we have struggled with and on the pediatric cardiology side is how do we identify an adult HCM specialist? It's not as easy as you may think. Sometimes this may come from word of mouth, right? You may have friends, relatives, otherwise that can give you an idea of who to go see. But it may be from a referral from your current provider. Who knows? I think that's the typical pathway. But I would argue one way you could do this is to go through folks like the HCMA or people that are on this lecture here currently this evening that can help you to find providers. I think one of the things that we've noted with COVID, one of the potential upsides, limited, but one of the potential upsides of COVID is that it has helped us to move more aggressively and quickly into this idea of telehealth. So now, could you see an HCM specialist somewhere on the other side of the globe? And the answer is yes, you could. And remember, when you talk about a good team for HCM, that includes a comprehensive team. So good imaging like echo and cardiac MRI. You may need a cardiac catheterization. You may need electrophysiology for ICDs and pacemakers. May need cardiac surgery potentially. Hopefully we could avoid that, but you never know. And other specialists that are involved in the HCM management plan. So what I would say emphatically is anticipate the process, right? Plan ahead, and communication with your current provider and your anticipated provider is absolutely essential. So begin the process early with a planned age of transition, we would say in conclusion. Set some idea of when we want this to happen. That's what we do in the adult congenital population. I think integration, availability of health information can make the process more streamlined. So start getting your records and all those things transferred over are hugely important. I would still state that there are advantages to being managed in an adult practice, and one of those could be in the form of access to things like mavacamten. But we all at the end understand this transition can be challenging, but remember, we're here to help. So thank you for the opportunity, and I look forward to hearing from you. Hello, John Jefferies, providers across.
Okay, we can turn him off now, Joel. He just looped again. There you go. John Jefferies is going to do it all over again. Okay, well, I think John brought up some very important points, and he's right. We need to document this. We need to get it in the literature. We need to educate pediatric cardiologists about how to psychologically and physically, and how we at the HCMA help parents understand the difference between Z-score measurements and adult measurements. They're different. You guys take images backwards from adults. Your right and lefts are actually right and lefts. Ours aren't. So I don't even think people realize that. So can one of you explain the differences just quickly about what an adult echo looks like and what a peds echo looks like when you're looking at the images? Somebody want to take that for me?
Yeah, we're anatomically correct and they're backwards and upside down. And also our pictures are much, much more beautiful. And we play for the kids when they're getting their images. So completely different world.
So right is right and left is left and up is up and down is down. And you get to watch TV and have entertainment, and we just get to sit there and stare at a wall.
Right.
Okay, I get you. So any other comments on what John had to say? I think he covered it quite nicely. Does anybody have any questions on this issue? We don't have any questions in the queue. And that concluded our last talk of the night, which I thought was a phenomenal night, even though it has been a wonky day, people, and just wonky things keep happening to me today. And we lost Christa halfway through this one, but we're back. We have a raised hand question. Raised hand question. We will allow you to talk in a moment, but I'm going to stop streaming on Facebook before I let you talk. So we're going to, oh God, we didn't wrap up the poll. So who was here tonight? We had 38% from the Northeast, 8% from the Southeast. We had 23% from the Midwest. We had the West. We had Canada. We had Europe. Nobody from New Zealand or Australia today. Sometimes they come and play with us. So 31% have HCM. 15% have a child with HCM. 5 do not have HCM, but their adolescent or child does. We have some medical providers here with us. We have somebody who's just curious. You spent 2.5 hours with us just curious about HCM and pediatric and adolescents. Kind of like you. You have you had your child or adolescent any of the following? So 46% were diagnosed in the last 2 years, 15% have ICD, 38% are on meds, 23% had septal reduction therapy. 2, I'm not sure if this is the parent or the children, had AFib. 8% have lost a family member. 62% had genetic testing. Numbers looking good there. The rest of you probably want to consider doing something like that. There was a bad question there that I don't know what happened there. Sorry about that. And what age were you diagnosed? So we have infant to a year, we had 31%, 1 to 3, 15%, 4 to 6, 15%, nobody in the 7 to 9 range, and 10 to 12 was 8%. So we had a we had a pretty typical HCM kind of diverse population there. So we're gonna finish up with them. Balaji has a question. I'll let you do your question or comment, and then we'll tell Facebook bye-bye.
We can talk about my question really, as you were talking about mental health.
Okay.
I mean, obviously you're doing a huge service to the HCMA community by having these sort of meetings. The idea came to me, why not a meeting of some key representatives from the institutions that are HCMA centers of excellence to cross-pollinate ideas on how to provide better mental health. Because we are all caught in this cardiology world, and that's what we think about. You know, we are constantly reading papers about myectomy or ICD or sudden death. Mental health, with all the best intentions in the world, is not staring us in the face every day. And we need to set up a system to help take care of those patients. Because, I mean, I don't know about how it is in other centers, but in our center, we are a HCMA center of excellence, but really what that means is we have Ahmad Masri, who's our adult HCMA, head of the adult HCM clinic, me in pediatrics, surgeons who know how to do myectomies, et cetera, et cetera. There is no administrative structure. We don't have a set aside administrator or even a secretary who actually works to, the hospital and the institution likes to, when it is relevant, say, oh, we are a HCMA center of excellence, but really they are not providing any infrastructure.
Well, that is a problem, and they should be doing that. And as their relationship with us stated, they've claimed that they're going to give that support. And most of our programs have nurse practitioners or coordinators to assist with that. So if you don't, then we need to have a conversation.
No.
To get that.
We have nurse practitioners and mid-levels and all that, but at the same time, we don't have a system for mental health.
No. So that is an issue. There are some simple processes that we're already looking at a couple of tablet-based in the waiting room, much like transplant. We do an assessment for the transplant patients in the transplant community. What is your mental health? Are there triggers? Now, what do we have time? What do we have the resources for to handle, and how are we going to refer up? So part of our Center of Excellence evaluation, I'm going to say for the past probably 3 years, have been the question, what are your mental health services? Whether it's, maybe they only have a social worker. Maybe they have a psychiatrist that is available to them, but they don't use it very often. Maybe they have a full therapy program available. So everybody's got something a little bit different. So we're going to do a survey of all of you and say, what do you have? What's going on? And if the answer is nothing, well, what's happening in your hospital? And then we'll go dig in and say, well, it looks like you have this, and that. How do we implement them together? I had a great talk this week or last week. That week went really fast. With the new team at Leahy. And I brought in the head of psychiatric services. And I said, what do you do here? He's like, oh, well, we're embedded in this department, and this department. I said, well, what does embedded mean to you? And they do quality assessments of the patient's quality of life and mental health services. And then there's a referral process, but it's still not perfect, but they have a department, and we're trying to develop out that service model so that we can take care of the whole patient and the whole family. There's other things that we didn't really dive into tonight because the topic is adolescents and peds. But in a family, when you have multiple family members with the same disease, and something bad, I saw what you did there, Julie, and something bad happens to a family member, death, complications, hospitalizations, syncope, that weighs on everybody in the family. I was doing a Big-Hearted Warrior tour two episodes ago. You can go back and watch the tape. And while I'm doing the meeting, my daughter passed out. And her friend called me from a restaurant around the corner from my office, thank God it wasn't across town, and said, Becca's on the ground, EMS is coming. And I said, I'll be right back. And I left the meeting running and I left it in the capable hands of Amy and Julie. And I ran to my daughter. And if you think that that didn't mess with my head for a while, like, okay, everything was quiet for a while, and now this is back again, just when you get comfortable, something else happens. So we're working on it.
Maybe I'm not putting my suggestion in the right way. What I'm saying is,
We need a comprehensive approach.
we in medicine, at least maybe I should just own up. Maybe Pete I can include. We learn from others, but we're also pretty competitive. When we see another center doing something in a different way or in a better way, we think to ourselves, oh, we have to up our game. And you can sort of pressure the whole community to come up with innovative solutions by getting us talking with each other, is what I'm saying.
We agree, and we're working on it. And I think the competitive nature of cardiology lends itself well to this. And I think if we challenge everybody to come up with creative solutions, that's going to be good. But we also have to be realistic in our knowledge that as a country, there is a deficit of mental health providers. So telemedicine, group therapy, group support, so you can touch 50 people at once instead of 1 or 2, those services can be tried. We're doing it with the discussion groups, and we're going to do some surveying of those discussion group participants to see if there's an improvement in their everyday quality of life because they're participating in those groups and because they feel supported. And I can tell you right off the bat, patients who go to centers of excellence versus community care, their mental health is better. They feel calmer. They feel they're in control of their health. They've got a great team on their side. They don't feel alone. They know they have resources to go to if they're not feeling well. So right off the bat, we know centers of excellence matter there. Now we just need to make them a little bit better. And I agree. Let's do a mental health hack, and let's get everybody thinking about what can you do. Don't tell me the limitations. We know those, but where can we find some space? And we can go there. I'm going to say goodbye to everybody on Facebook, and then we're going to go over to the questions over there. Oh, that was your hand raised before. Okay. So bye, Facebook. Thank you for joining.